And welcome to the third day of the webinar, and we will start our session talking about ventilator-associated pneumonia. About the ventilator-associated pneumonia. فإذا حنبتدي أول سيشن نتكلم عن سيشن اسمها ventilated associated pneumonia, and this is very important, and this is one of the complications that it might happen to the patient in ICU who is under ventilator for a period of time. As in VAP or ventilator associated pneumonia, it's one of the complications for the patient who are on mechanical ventilator. But not all patients will be on VAP. هي مش تجي لكل المرضى بذات الوقت. There is causes, there is complication, and there is indication, and there is treatment, and there is patient they might end with different complication. We will see now what do you mean by VAP or ventilator associated pneumonia, and a very interesting session because I'm going to show you a picture and you will see how the patient will have a VAP. In this session, we are going to cover the following objectives. First of all, what are the definition of pneumonia generally? Explain the pathophysiology of pneumonia and the list of classification. What do you mean by VAP? What do you mean by VAE? And what are the risk factors of VAP? What are the VAP prevention and recommendation? List of bundles. What do you mean by bundle? Bundle are a group of intervention. كيف ممكن نكافح نحن او نمنع يصير في عندنا الفنتيليتد اسوشيتد عند المرضى اللي بيكون على المكنه او على التنفس الاصطناعي. Describe medical management and what will be the nursing management. So this is for you to know, first of all, that VAP will come to a patient who are on mechanical ventilator during a period of time, and you will see how we measure this period of time. First of all, let me start with the pneumonia. It's an acute inflammation of the lungs that is caused by an infectious agent that can lead to alveolar consolidation. As you see here, and let's take the COVID scenario, let's see. As you see here, this is the lung of the patient. It's inflated, or there is inflammation of, let me put it more big. There is inflammation here of the lungs due to, it might be bacteria or to a virus. And this is what happened, let's say, during the COVID cases. You take the example. Now you would be exposed to a patient through coughing or sneezing or whatever, and this is the bacteria or the germ will enter and it will go to your lungs, and later on you will see a patient that ending on high flow oxygen, and later on they will be on mechanical ventilator, going to organ failure, going to ECMO and whatever. And this is the typical picture of what will happen with the COVID patient or with the corona patient. But this is for your information on this picture, how the corona will start with the patient, or how the pneumonia, let's say, because will happen. It might be, for instance, it might be bacterial or viral, and through the coughing, sneezing, or up to this moment, that's if you take the COVID case, it's not mentioned or not say 100% which is airborne or droplet, but mainly it's going through droplet by coughing, let's say coughing or sneezing or whatever. And this is the journey to go through the upper respiratory, and it will go to your lungs, and you will end with pneumonia. So this is a clear picture how you will get the pneumonia. Can you hear me? لأن المعظم يقول الصوت واضح، بس حدا بيقول الصوت رديء. ممكن يكون يا أخ ناصر شيك من عندك. انا بالنسبه لي قبل الكل بيقولوا لي انه الصوت واضح وممتاز، بقى ممكن يكون يا حبيبنا الصوت من عندك. اوكي طيب، فاذا this is مثل ما حكينا هي طيب now في عندنا نحن different types of pneumonia. pneumonia مش بس نحن الحين نتكلم عن النمونيا اللي بتيجي على المرضى اللي بتكون على التنفس الاصطناعي، على الميكانيكال فنتيليتر. Before start with this we have different types of pneumonia. فعندنا عدة أنواع من النمونيا اللي بتيجي. أول شغلة بنسميها community acquired pneumonia. And this is, for example, you could take the example of COVID. لأن بتيجي من الكوميونتي، من الإكسبوجر. For example, you have been exposed to a patient who has pneumonia, who get it from different places from the community. Okay, and you know, after you get it from the community, then from outside and or within 48 hours of admission to the hospital. يعني إذا أنت اليوم أخذت pneumonia من برا from someone and you have been admitted to the hospital because you are not feeling well. This is, we call it a community acquired pneumonia. ليش؟ لأنه you did not pass the 48 to 72 hours in the hospital. If you will get it after 72 hours of the hospitalization, we call it a hospital acquired pneumonia. وضحت؟ فإذا community, let's say, what's happened now in the community? You have been exposed to a COVID patient, for example, or patient with viral infection or whatever, and after that you are not feeling well, you have body weakness, whatever, high little temperature. Then what happened? Then you are admitted to the hospital and already you have the symptoms. يعني أنت جيت على المستشفى already وعندك العوارض, you have the symptoms. We can't call this one it's hospital acquired pneumonia. It's a community because already you brought it from the community. وضحت؟ طيب. Now let's say you have been admitted to the hospital just for a simple procedure. Simple procedure. Let's say you have abdominal pain or whatever, and you have been admitted. Then after 72 hours of admission, you start to have pneumonia or signs and symptoms of pneumonia. In this case, we call it the infection was spreading in the hospital, and we call it a hospital-acquired pneumonia. فعندنا كمان النوع الثالث من النمونيا اللي هي health care associated pneumonia، هي اللي بتنتقل بين الستاف، اللي بتنتقل بين الستاف من ستاف لستاف. مثل ما حكينا بيكون مثلا staff he was exposed to a patient or whatever and he exposed the other colleague ممكن يكون زملائه بالعمل and we have a cross infection because this is what called the healthcare associated pneumonia. وضحت؟ فإذا هودي اللي هن ثلاث أنواع من this is the three case of pneumonia. Clear؟ واضحة بالنسبة لكم أنواع النمونيا انفهمت؟ لأنه ما فيني فوت بخصال بالضبط إلا ما تكونوا عرفتوا تميزوا بين أنواع النمونيا اللي هي الكوميونتي اللي هي الهوسبيتال واللي هي الستاف الهيلث كير اسوشيتد نمونيا. عظيم. نحن وقت بدنا نحكي عن الفنتيليتد اسوشيتد نمونيا it will come under which category do you think? Under the first community or hospital or healthcare associated pneumonia? How do you think this is a patient on ventilator? Okay, first it will come under which category do you think? VAP, hospital, thank you. It will come under the hospital category, hospital acquired pneumonia. Do you think what happened? Let me give you a case scenarios. أنا بعرف إن some of you they are not a critical care and emergency background. بعرف بعض المشتركين معنا participants, but at least I want to simplify it to make it clear to everyone. تعم الفائدة على الجميع. مشان هيك يعني الترفض بالتفاصيل الدقيقة جدا من شركة. طيب I will give you a case scenario ومن هون نبلش السجن. For example, we have a patient. who have been admitted through the emergency department post-road RTA or road traffic accident. Okay, this patient, he was stabilized in the emergency department. They stopped the bleeding, and the GCS is 9/15. The GCS is 9/15. Do you think what needs to be done؟ شو لازم نتصور؟ شو لازم نعمل؟ إذا المريض عنده GCS، إذا what should be done؟ We need to go for intubation. يعني دائما وقت الكلاسيكو كوما درجة الوعي عند المريض هي لازم تكون 15 من 15، درجة الوعي عند المريض هي أقل من 9 أو 9 على الأقل، لازم نروح على intubation. عظمة. I intubate that patient. تذكروا السيناريو، السيناريو راح يرافقنا لآخر السيشن. We intubate the patient, and there was a bed available in ICUs, and we transfer the patient to ICU for the continuity of care and the follow-up. حديت هون everything is okay and nothing to be worried. The case is clear. Patient is intubated, post-road traffic accident, stabilized in EMS, and we transfer the patient to the ICUs just for further investigation. After 48 hours, فإذا كان المريض الحين لحوق العناية المركزة، هذا هو المريض لحوق الحين. This is patient, he is in ICUs. Today we are on، نحن اليوم كم بالشهر؟ نحن اليوم we are on 30. Let's say this incident it happened today. We are on 30th of September. The patient was admitted to ICU, stabilized on mechanical ventilator, AC mode, whatever. 30, the patient, he was okay, doing well, no problem at all. On the 1st of October, he was doing well, no complication, stabilized, receiving his medication on time, and the situation started to improve. On the 2nd of October, the patient, he started having signs and symptoms of pneumonia, which is going to talk about it. فإذا, do you think this is a hospital acquired pneumonia or community acquired pneumonia؟ انتبهوا، المريض اجى من برا وبعد 48 ساعة قطع 48 ساعة وصار المريض عنده signs and symptoms of that. اللي هو المريض اللي هنا لحوا هذا على الفنتيليتر. What do you think? It's a hospital acquired or this is a ventilator associated pneumonia؟ ليش يا أخت زينب قلت لنا الهوسبيتال؟ اللي قال لي هوسبيتال ليش؟ Why? After, thank you أخ علي. فإذا because this is VAP. شكرا أخت زينب، لأنه هذا المريض حددت لكم وقت أنا قلت لكم، بعد حطيت لكم السيناريو وقت لكم هذا المريض بعد 48 ساعة بلش عنده العلامات الحيوية أو بلش عنده علامات الانفكشن ventilator associated. وهذه الصورة we need to base our session is based on this picture. تذكروا كثير من هذا المريض كان بالطوارئ ونقل على العناية المركزة، وهذا هون على التنفس الصناعي connected to a machine, and he's totally depending on the machine, and he's connected to the monitor for hemodynamically monitor the patient. And this is a picture, يعني how the pneumonia it might happen already. نحن نتكلم عن or we explain about it. Now, my question: why do you think since there is a high risk of mortality, there is a lot of statistics saying that the mortality rate is very high for a patient on mechanical ventilator type. Why we put a patient on mechanical ventilator? Or for what reason we put the patient on mechanical ventilator? Because the mechanical ventilation is a life-saving for a patient who are critically ill or in respiratory failure. If I have a patient who has a respiratory distress going to a respiratory failure, there is no way to survive unless he's on mechanical ventilator. Patient who is losing his airway, who is losing the level of consciousness or with decreased level of consciousness, there is no way to survive that patient unless he's on mechanical ventilator. As a mechanical ventilator, it's equals on life saving. We are not to put the patient on mechanical ventilator unless it's needed because the mortality is very high and the outcome is very poor outcome. Because the mortality rate it's very high and the outcome of the patient will be very low. Minor organ failure and the complications so much. In the United States, more than 300,000 patients are on mechanical ventilator per year. And there is always, as we said, there is high complication, high mortality rate, and a very poor outcomes, including the death. Patient, if he has EVAP, he might have gone to distress or he might go to sepsis. لأنه because of the infection. إذا ما بتوقف الشغل على الفاب بس, he might go for sepsis and pulmonary edema. كلمة المريض. Yesterday I was explaining about the length of stay. مثل ما حكينا, longer stays in ICU and hospital, it will increase the healthcare cost and increase the disability and death. كل ما المريض طول أكثر بالICU, كل ما المريض يكون على الفنتيليتر, كل ما المريض يكون at high risk of having a ventilator associated pneumonia. وحكينا كثير عن الاوتكم والريسك. No signs showed first. Yes, there is sign that أنا راح يجيكم بالسلايد الجاي راح أعطيكم بعد ما هذا السيناريو كيف. طيب, I will give you a quick question or quick quiz about the patient. We have a patient who developed signs of pneumonia within 24 hours of admission. After admission to the hospital from home. He, from home, I said to have, what type of pneumonia? This is a, do you think A, B, C, and D? We need to memorize the abbreviation. Do you think which type we could give it? 3, 1, or 2, or 3, or 4? A community معظم عم بيقولوا a community acquired pneumonia. This is community acquired pneumonia. ليش؟ تذكروا لأنه it's within 24 hours. وقت بقلح وقت بتصير more than 48 hours ساعتها ببلش احكي عن ventilated associated pneumonia. عظيم, thank you. فإذا نبلش هلا. في شغلتين we need to know about some of the definition before starting. أول شغلة VAE. انتبهوا هلا بدنا نبلش بسبب الموضوع. VAE في عندنا الفاب وفي عندنا الفاك وفي عندنا الايفا. ثلاثة. How to differentiate? VAE a broad range of condition and complication occurring in mechanical ventilated patient. فإذا how it's a complication اللي بيجوا عند المريض اللي عنده الميكانيكال ventilator. There are 3 يعني definition. First of all, المريض مش دغري بيروح على الفاب. يعني المريض just for your information. حتى إذا بعد 48 hours of admission ببلش عنده العلامات. We cannot diagnose it as VAP. ممكن يكون شيء غير. First of all, بتبلش with a ventilator associated condition. What do you mean by ventilator associated condition? يعني بتيجي VAC, IVAC, VAP. مش دغري أنا بروح بعد 48 ساعة صار عنده حرارة ومريض بقول this is a VAP. No. في عندي مثل ما بقولوا pathway. في عندي طريق diagnosis. First of all, we have what we call the ventilator associated condition. What do I mean by ventilator associated condition, do you think? or VAC. Then I have the ventilator associated condition. As I'm just what you need to know from this slide. I will not go directly to the VAC. First, I will go to the VAC, then IVAC, then VAP. And I'm going to explain one by one. The first, it's the ventilated associated events or conditions, sorry. Then infection related to ventilated associated complication or IVAC, and possible and probable VAP or خلينا نشوف what do you mean by VAP. إذا بنرجع على please focus with me. إذا بنرجع على حالة المريض اللي قبل إنه المريض he was admitted to the EMS through the EMS, stabilized in EMS, admitted to the ICUs for investigation and for follow-up, and he's under the monitor just to see the condition of the patient. Now, it was okay. After a period of stability or improvement on the ventilator, بعد 48 ساعة حسيت إنه المريض he started to improve. But suddenly, he started to have at least one of the following worsening oxygenation. ببلش المشكلة عنده بعد ما في لا أي infection ولا أي شيء. لاحظ عند المريض إنه عنده some of the worsening in the oxygenation. مثل ما قلت لكم المريض he was stable, doing well, no problem at all, stabilized. He is admitted in ICU under close observation, no problem at all. After this stabilization or after this stability period, the patient start to have some signs and symptoms of worsening of the oxygenation. ببلش يصير في عنده تغيرات بالاكسجينيشن بالدم عنده. مثلا انتم بتعرفوا المرضى اللي بيكون على الفنتيليتر بيكون على الفنتيليتر settings والمود اوف فنتيليتر الاف اي او 2 والبيب والى اخره. بنبلش نلاحظ اللي بيكونوا بالار تي وبيشتغلوا بالاي سي يوز they understand what do I mean by this. بنلاحظ هون انه في الاف اي او 2 it will increase and البيب increase. شو معناتها يعني؟ هودي بيعنوا انه في شيء he is compensated or there is something abnormal in the oxygenation. Otherwise they need to be on the normal way. ما في مشكلة فيهم. فإذا هون increase by 0.20 over the daily minimum of IO2, and here it's increased by 3 centimeters by the daily minimum of PIP. They increase. هذا بيعني there is increase on the work of breathing. وضحت؟ فإذا أنا ببلش هون بلاحظ بعد ما بحكي عن انتبهوا نحن بال VAC or ventilated associated condition أنا بعد ما جبت سيرة الفاب نهائيا. There is nothing to do to the VAP. There is no diagnosis. بس أنا لاحظت after 48 hours of stabilization in your ventilator settings they start to increase. What this means increase the work of breathing, and there is something that I need to take it in consideration. I cannot neglect it. وضحت لهون؟ انتبهوا لازم تتابعوا معي من الأول. أنا أي شيء بيصير ما بعد فينا بتضيعوا الموضوع. It's clear what they mean by ventilated associated condition. Or do you want me to repeat? Okay. طيب. إذا هون المريض أنا بعد ما في ولا انفكشن ولا في فاب ولا نيمونيا ولا أي شيء. كل اللي بين عندي إنه صار في worsening بالoxygenation. Now I need to know what are the causes of this worsening of oxygenation. Why the patient, the oxygenation settings become worse. فإذا this is after 48 hours. هذا بالday مثل ما قلنا this is 24 hours. After the third days شو صار عندي أنا؟ After فإذا نحن هلا عندي الفاك only or events. After the period of time, after 3 days on mechanical ventilator, the patient start, in addition to the increase of or the worsening of the oxygenation, لاحظت إنه المريض بلش يعني عنده temperature, high temperature, which is more than 38, or the WBC become high. فإذا لاحظت إنه المريض باليوم الرابع بلش عندي موضوع اللي هو مش بس الأكسجينيشن worsening، صار في عندي موضوع اللي هو high temperature صار في عندي high temperature أو بين عندي بالدبليو بي سي اتس فيري هاي. فإذا بلش عندي أنا الكونديشن بين worsening of oxygenation، بس ما عينت لي شيء، ما اعتمدت عليها، بس أنا بقول I will go for further investigation. رحت على الانفستيجيشن بس بين عندي أنا بعد on the 4th day إنه المريض بلش عنده temperature والدبليو بي سي become high and a new antimicrobial agent is started and it's continued for. فإذا أنا هون بلشت أقول it's a possible ventilated associated pneumonia بس بعد ما بين عندي شيء. قلت شو هي الفاك والاي فاك؟ إذا الفاك كونديشن اللي هي أنا صار عندي مشكلة بالأكسجينيشن، الاي فاك المشكلة بالأكسجينيشن، بعدين صار في عندي اللي هي الساينز اند سيمبتومز اوف انفكشن اللي بين عندي temperature، بس بعدني لهلا I can't say it's a ventilated associated pneumonia. It might be caused through another agent or through another reason that we don't know. But I will put under question mark that it might be a ventilated associated pneumonia. Now, what will happen بعد ما خلصت الحالة هنا؟ After the IVAC on the daily or mechanical ventilator صار في عندي respiratory secretion or purulent respiratory secretion from the trachea, which is contained in neutrophils and whatever. And أخذت positive، أخذت من هذه secretion a culture of the sputum from the endotracheal tube and just to see what happened. إذا أنا صار في عندي secretion، لاحظت إنه secretion من ال ETP، أخذت أنا a blood culture، أخذت منها culture and it become a positive culture, which is a positive ventilated associated pneumonia. هذه بتساعدها تصير من الفاك. Okay, فإذا this is the chain how the patient he got AVA. رح أجي أختصر لكم إياها كلياتها. فإذا شفتوا شو صار. This is I will give you 1 minute just see it properly قبل ما أرجع أعيدكم إياها لأنه for me هذه بتختصر كثير للسيشن. This is the whole session. It's including on this one. فإذا لاحظوا شو صار هنا مثل ما حكينا. شوفوا شو صار، إنه المريض كان على الميكانيكال فنتيليتر لأكثر من يومين for the patient after in more than 2 days on intubation. After a period he was stable. After a period of stability صار في عنده worsening بالاكسجينيشن. بعد worsening of oxygenation ما كان it's okay. I said it's okay, no problem. Let me see what will happen later. بعد worsening of oxygenation صار في عندي high temperature وال WBC high. بعدين صار في عندي secretion. أخذت culture and it became positive. فإذا هون it was a VAC, here IVAC and here it's a VAC. فإذا نحفظوا VAC or ventilation associated condition حكينا عنها. Infection associated complication اللي هي الIVAC. هون صار في عندنا the possible or probable VAP لأنها it was diagnosed by أخذنا culture and it's become a positive culture, which is a positive ventilated associated pneumonia. Awesome. مين فاذا الباثوفيزيولوجي او كيف بتصير الفالف now I think it's clear to all of you. وضحت الموضوع هلا now we need to know what are the risk factors. شو هي الريسك فاكتورز اللي بتخلي المريض يصير في عنده فالف؟ يعني what are the risk factors that the patient will have in order to have a valve. أول شغلة increase age لأنه بتعرفوا low immunity system or weak immunity system when you become older you will have your immunity system will become low and the patient more than 55 years old they are at, in case they will go for intubation or for a reason they are intubated they will have risk of ventilated associated pneumonia. Chronic lung disease, whatever, and always patients who have a lung problem or respiratory problem, especially those during the COVID pandemic, they were at high risk of going on ventilator, especially those who have asthma and bronchitis, bronchiolitis, whatever. The lung disease, it will increase the risk of ventilated associated pneumonia. Depressed consciousness, aspiration pneumonia, especially those who are on ventilator, if they have aspiration pneumonia, chest or upper abdominal surgery, the presence of intracranial pressure monitoring, previous antibiotic exposure, reintubation, what نعمل للمريض intubation and reintubation or a long intubation. ليش احنا المرضى اللي بيكونوا على we cannot keep the patient on ventilator for long time نحطه على tracheostomy. كمان قصة الريintubation لأنه if you will intubate and reintubate always the patient is at high risk. لأنه intubation and extubation at the end it's a procedure. You are introducing an external bodies to your body. In the ETT tube, this is an external body introduced to your body inside your body through an invasive procedure. This is at high risk. And frequent ventilated circuit changes. I will show you now what do you mean by the circuit. هي الامدادات اللي بتيجي من مكنه التنفس الصناعي على اللاين تبع البيشنت التيوبز والى اخره. اذا على طول بنغيرها it's at some point you are exposing the patient to infection, paralysis and malnutrition. هذه كلياتهم they are at risk of this is the risk factors of ventilated associated pneumonia. Now, how we could prevent the intubation or the recommendation for prevention of ventilated associated pneumonia. First of all, by going for orotracheal intubation. نحن بنروح على ما بنروح على النيزوتراكيال، بنروح على الاوروتراكيال like here. إذا بتشوفوا هون الصورة أو البيكتشر هنا بتشوفوا نحن هون احنا على اورال ما فينا نروح على النيزل. النيزل there is risk of complication and it's a dirty area. ما فينا نحطها بال this is we prefer always to go for orotracheal intubation unless there is a contraindication. For example, we have fracture in the mandible, for example, for a reason. We can't go for oral intubation, we will go for nasal intubation. Always we need to maintain an aseptic technique. This is an invasive procedure. We are introducing an external bodies to our lungs or to our trachea. We need to maintain or to have an aseptic technique. يعني تكون اشياء معموله بشكل يعني مضبوط كويس، مش انه sterile way. Maintain a ETT cuff at least 20 centimeters ونحن نشوف and perform oral care with chlorhexidine. Why oral care in this area? This is the most area where the bacteria and germ will stay. If you did not clean it well and properly, it will go through the circuit, the tube to your trachea, and you will have a infection. كمان الاكويبمنت مثل ما شفتوا هيدي الفنتليتر هل السيركت اللي عم نكون عاملين السيركت وين نبلش؟ This is the ventilator. هيدي السيركت as you see tube قبل circuit it will go through a tube. هي اول كونكشن. ده بيجي عندي كونكشن ثاني على التيوب وكونكشن ثاني من التيوب على التري لانج. This is هيدي كلها we call it a circuit. مثل ما بتعرفوا infection it might be إذا ما أخذنا sterile way it might be here. يعني إذا الأب infection هو ممكن ياخذها دغري على التراكية. It might be here, and most of the time it might be here. And it might be through aspiration. The gastric contents, it will go through the tube here, and it might cause an infection. فإذا كلها هي هنا we need to be careful and to take all the prevention in order to preventing the and always we need to wear a gloves. But a gloves ما فينا نشتغل. كمان respiratory, this is another way just to prevent the bug. But use sterile water to fill bubbling humidifier. It needs to be humidified. النيبوليزاير والى اخره. كمان this is مثل ما حكينا امبارح شرحنا عنه قصه الفنتليتر واليانكر سكشن اللي هي على طول. It needs to be هذه اليانكر سكشن اللي فيها انتم بتعرفوا المريض is on ventilator كل الجاس الكونتنتس يعني sometimes we need to go for suction. بتعرفوا المريض يكون على الفنتليتر وقت بيصير ساتوريتد اول شغله بنعملها بنجو فور سكشن اند بوباجنج لانه بيكون في بلوكج على التيوب من اي مطرح نتيجه السكريشن. Always we need to go for suctioning, but the suctioning we will use the suction catheter او اليانكر catheter هو اللي بنستعمله على طول مشان نعمل suctioning لانه بس اليانكر كمان it's an external source ما في استعمله على وقت طويل لازم كل 24 ساعه we need to change the yanker suction. We need to change it every 24 hours. Any question? واضحة الأشياء؟ It's clear. هو موضوع صراحة طويل بس شيق يعني you will gain a lot of information. تعرف كيف بيصير الفاب عند المريض. أوكي عظيم. Thank you. فإذا مثل ما حكينا we need to avoid the intubation and extubation and minimize the sedation. Do you think why do we need to minimize sedation and how by minimizing the sedation we will decrease the risk of VAP? What are the relation between the sedation and VAP? Why by minimizing the sedation we will decrease the risk of ventilator associated pneumonia? Who could tell me? Depression risk. Thank you, Khadija. Part sedation. You are depressed respiration. صار مريض يعني أنت عم تجبر يعني he's skipping a بعدين وقت بدك تعمل extubation or healing process it will take time لأنه المريض already صار معود على قصة sedation. Means you are extending the time of intubation بدل ما المريض حطيته. أنا ليش بصير نحن ما بنعمل دغري مش دغري بنروح على الاكستوبيشن دايركتلي بنصير نعمل بنسميها الويننج بروسس. الويننج بروسس بنبلش نخفف السيديشن شوي ما في وقفها فرد مره. ليش؟ تبلد هالمريض يبلش الرئتين تتعود تشتغل بشكل تعتمد على نفسها مش على الفنتيليتر بشكل كلي. انا وقتها بخفف السيديشن المريض بوقتها انا بتاكد انه كل شيء كويس ساعتها I will stop sedation وبعمل الاكستوبيشن. انا وقتها بعطي extra sedation means extra timing on ventilator and it will take time for extubation. مشان هيك we need to decrease our sedation ما نعطي بشكل كثير. And always we need to assess once the patient is ready for extubation we will go for extubation and you will not delay the extubation لأنه المريض مثل كل ما ضل الوقت على الفنتيليتر كل ما يعني كل ما يكون at high risk of VAP. هيك فاذا this is the tube هذا before this is the introduction. شفتوا كيف 30 degree to 45 degree وشفتوا كيف التيوب this is the tube and it will go directly through the trachea to the two lungs, and this is how to do this is the suction source. We need to minimize the pooling of secretion above the ATT cuff. Avoid supine position. ما بنخلي مرة على supine position. ليش؟ Why do you need to avoid this supine position, do you think? Why do we need to avoid the supine position? To avoid the aspiration. Thank you, Khadija. To avoid the aspiration pneumonia or the aspiration of the gastric contents and maintain ventilator circuit. مثل ما تكلمنا كمان قصة الكلورهكسيدين كمان we need to clean the mouth of the patient لأنه هي أكثر منطقة هنا ممكن يكون فيها بكتيريا وجرم وفيروس وإلى آخره. وهذا الشيء if you did not clean it properly we expose the patient of high risk of aspiration of infection. نتيجة this is it's not a clean area. We need to clean with chlorhexidine. فإذا مثل ما تكلمنا this is what نحن نتكلم الحين عن الفاب bundles اللي هي group of practice or group of intervention. When you put it together it will lead to a better outcome. إذا عدة إجراءات بناخذها مع بعض لأنه وقت بناخذها مع بعض it will lead بيكون الأوتكم أضبط. يعني هول الإجراءات اللي شايفينهم هون we need to take it in consideration in order to have a good outcome. أول شغلة مثل ما حكينا the first bundle is to have of bed elevated 30 to 45 degree لأنه مثل ما تكلمنا هاي البوزيشن للمريض اللي بيكون على الفنتليتر. This is the position, this is the best position to avoid the gastric contents. And in this position, you look here, there is no way just to have a aspiration pneumonia or gastric contents to go back to the lungs and the tracheal area. It might be a high risk of infection. الأورال كلورهكسيدين مثل ما تكلمنا عنها we need to clean the mouth of the patient. كمان stress ulcer prophylaxis and we will give it mission just to avoid the gastric contents. Daily sedation assessment بنسميها الراس or rhythmic agitation. يعني المريض أنا كل يوم بصير خفف السيديشن بخفف الفنتليتر settings and to see what will be the reaction of the patient if he is doing well. كل ما if he's doing well أنا بخفف السيديشن أكثر توصل لمرحلة إنه there is no need for sedation and he could depend 100% on himself on the ventilator. ببطل أنا أروح على مثلا الاي او الاسيست مود او الاسيست كنترول مود انه الفنتليتر هو عم يعطي. لا بصير تخفف مثلا الفنتليتر ايش بدها مثلا بيعطي نحن اور ريسبيريشن 16 breathing per minute. وقت بيكون المريض totally depending on the ventilator بيكون عم يعمل full sedation and the respiration or the machine it's going is giving to the patient 16 breathing per minute. طيب how I'm going to extubation خفف السيديشن بيصير المريض ياخذ 14 breathing per minute from the ventilator and 2 by himself. يعني بيصير الفنتليتر يعطي مثلا 1 2 3 4 5 6 بعدين بيوقف بياخذ المريض يوقف بيجرب بيصير المريض ياخذ هو هالفنتليتر او هالتنفس منه من نفسه. بنرجع it's okay بيرجع يروح 7 8 9 10 11 12 and 1 ventilation by the patient. هاي ماشين مبرمج. If he's doing well ما في برجع ببلش instead of 2 بروح على 4 1 2 3 1 respiration 1 2 3 1 ventilation 1 2 3 1 ventilation 1 2 3 1 بصير انا 4 كون عم بخفف السيديشن بصير انزل تصير المريض خلص he could take his breathing at least 13 to 14 breathing per minute by himself. بطل في sedation انا بروح على extubation and this is what we call in الراس or rhythmic agitation. ديب فين ترومبوزس كمان الدي في تي بروفيلاكسس بنحط الدي في تي سوكس والى اخره. ليش؟ لانه مشان تو افويد، لانه المريض هيز اون فلات بوزيشن والمريض هيز نوت موفينج نوت امبوليتنج، وهذا هالشيء بيعرض المريض يكون في عنده بالمونري امبوليزم. مشان هيك to avoid the pulmonary embolism I need to give the deep vein thrombosis prophylaxis. And this is what we call the 5 bundles of mechanical of the valve. This is how we could prevent the valve. We will prevent the valve on this way by applying the 5 bundles. We need to apply the 5 bundles. ما في يقول انه I will apply, let's say 1 and 2 and 3 and 4 and 5. There is no need. Or we could do it later. لا, this is a group of intervention that needs to be applied together. كلياتهم بدي استعمل 5 elements of the 5 of the valve bundles. اللي هو مثل ما شفنا رجع شايفيني هون البيكتشر، شفتوا هون سرير المريض 30 to 45 degree. الاورال كير للمريض بس كلورهكسيدين مثل ما حكينا بينعمل كل 30 to 44 كل 4 ساعات 40 hours 4 hours. And this is the adult oral care protocol. This is what we need to do. بالأخص وقت يكون ventilated patient مثل ما قلت every 4 to 6 hours إذا كان على الفنتيليشن or we need to do the oral care. هذا الأورال care protocol just for your information. ومثل ما تكلمنا دائما بنروح على الاوروجاستريك rather than النيزوجاستريك لانه اتس ديرتي اريا ما في. والدي في تي بروفيلاكسس شفته هنا. لانه ليش بنستعمل دي في تي بروفيلاكسس؟ لانه اي نيد تو بي كيرفول انه المريض ما يمعرض للبالمونري دي في تي او البالمونري امبوليزم. يكون في مثلا من هنا من اللور ليمب شيء يطلع على اللانكس ومسكر الشرايين ويعمل بالمونري امبوليزم، تجلط الرئوي. والبيبتيك ألسر بروفيلاكسس مثل ما تكلمنا ممكن تعطوا الزنتك او ممكن تعطوا الأوميبرازول. But we need to give it to that patient. يا اما مثل ما حكينا الأوميبرازول او الزنتك. فإذا هودي برجع بختصر كلهم. This is the bundles. Have a look. وشفتوا المريض هون we apply a bundles. عملنا 6 bundles هنا. ومثل ما شفتوا المريض he is always صحيح على but he is awake and he could see everything. This is we avoid him from the valve. هذا المريض you could say that the patient he is out of the valve because we apply all the measures. كل الميجرز we apply it. And Marid, now you could see that the patient he is ready for extubation right now. شوف Marid now he is ready for extubation. There is no problem at all. شوفوا الفالف bundles outcome. نحن when we apply bundles شوفوا الكومبلاينس ريت compared to يعني هون نحن عندنا مريض اوريدي بتشوفوا هنا باللون الازرق او البلو كلر هن المرضى اللي we apply the bundles compared to patients who did not apply the bundles. هون بتشوفوا انه when we apply the bundles كان في عندنا مثلا من 33.3% طلعت لل 80.3%. This is really statistics. Okay بتشوفوا. بينما هون once we did not وشوفوا الفاب ريت كيف نزلت يعني عليت. كل ما علينا الكومبليت كومبلاينس ريت كل ما الفاب ريت نزلت. كانت 30 صار 6.4 وهون من 33.3 when we applied 80.3 كان في عندنا compliance، صار في عندنا نسبة الفاب 6.4، وقتها كان 33.3 كانت نسبة الفاب 30. وضحت الصورة هون؟ أنا شفتوا قديش when we apply the bundles and we took the intervention قديش نسبة الفاب bundles أو الفاب الأوتكم كانت كويسة. كمان قصة بالفاب in case a patient already هي خلص sometimes we might apply all the intervention but برضه المريض بعد عنده فاب ما خلص منه. نحن we need to apply the proper antibiotics based on the result of the culture. مثل ما حكينا امبارح انه اكثر شيء بخاف من قصه الانتيبيوتكس اللي هي قصه الريزيستنت، بيكون في عنده ريزيستنت على الموضوع. Nursing management and nursing they are playing a big role on the prevention of the VAP and they will apply all the measures. أكثر ناس مني they will apply all the measures just to prevent the VAP. من turning position ومن suctioning وإلى آخره. طيب let me give you a scenario before starting هذا آخر شيء بيكون بالسيشن. We have a 50-year-old gentleman, history of hypertension and diabetes, is admitted to the hospital after a road traffic accident on the 2nd of February. Okay, now this is your turn just to answer me. Patient is intubed إذن دخل على نتيجة حادث ب 2 فبراير. He is intubated, sedated, ventilated, and moved to ICU for monitoring. Day 3 on mechanical ventilator. Patient started desaturation and low PaO2. PEEP is increasing. تذكروا كل شرحتني خلال السؤال. You need to remember what I explained to you. What do we call this VAE algorithm? What do you call this? تحدث هلا what we call this? VA. Thank you. I am very happy. Finally, collaboration ومعكم. We are very glad that we are with you in this symposium. Really, your information are perfect. أنا مبسوط إنه كل الانفورميشن أخذتوها بشكل excellent. ممتازين. فإذا بتقولي إنه this is a ventilation associated condition. بعدنا عم نحكي بالcondition بعد بحكي. شو صار عندي بعدين؟ باليوم الرابع WBC عليت and high temperature and a pan culture sand and was started on course positive and on tazocine. بلشنا tazocine for 7 days. What we call this? بعد infection rate. نتذكر إن إحنا قلنا إنه ايفت لأنه إحنا قلنا بعد not confirmed. صار في عندي مضبوط عليت WBC أو بعد ما حكينا عن الحر عليت WBC. أصلاً بعدنا الكونديشن. باليوم الخامس أخذنا الكالتشر بعد ما في يعمل دايجنوز إلا بكون أخذت الكالتشر. وصار في عندي أنا positive. What we call this? This is a possible ventilated associated pneumonia لأنه نحن أخذنا الكالتشر بس بعد ما أجت الريزلت هون we get the result and the patient he is a ventilated associated pneumonia. عظيم. فإذا this is the prevention summary. Hand hygiene, coughing and sneezing etiquette and أكثر شيء مثل ما حكينا قصة الكافينج والسنيزنج لأنه أكثر شيء تعرضنا للنمونيا. Lower your risk of pneumonia by the vaccination. Avoid unnecessary intubation and staff education. Prevention, education, and detention. Did you enjoy the session? It's clear. Any question before moving to the second session? Do you have any question? أي سؤال بتحبوا تسألوني إياه before moving to the second session? Any question before? Okay. Present 5 minutes and you'll be moving to the next session. Okay. احنا نبتدي بالسيشن الثاني. Okay. Now, if you have a patient on trauma, دايما what you have a patient on trauma, you need to stabilize it. نحن we cannot elevate or move if he has a trauma بالاخص قسم الطوارئ لانه المين idea in case we have a trauma to stabilize the patient. انا ما في اعلي له راسه or we cannot elevate the head if he has a trauma unless I make sure there is no injury. Okay, be careful. Patient on trauma, he will be staying on his position. We will stabilize it and we can do the suction. We cannot, we cannot elevate the head unless make sure إنه أنا ما عندي أي مشاكل بالعمود الفقري أو بالرأس وإلى آخره. فإذا we cannot move. I cannot move the patient. I need to stabilize it. First priority is to stabilize and doing the section on the supine position. I cannot move it unless I make sure that there is no problem at all, there is no fracture, there is no injury, there is no complication. But trauma patient, we need to be careful. We need to stabilize it. ما بحرك المريض لأتأكد إنه there is no problem. Okay, thank you. A few minutes and we'll start with the next session. Okay, good morning. Assalamu alaikum جميعا. And our next session for today it will be نحن مثل ما تكلمنا شفتوا بالجدول انه نحن صراحة هو جدول كثير كبير يعني في كثير من المحاضرات وممكن ده نعطيكم محاضرات على فترة كبيرة يعني بس انه نحن عم نجرب ناخذ المحاضرات اللي بتهمكم يعني تكون الفائدة عند الجميع ونعطي من كل شيء يعني يكون في فكرة عن كل شيء. But 3 days it's not enough صراحة. If you will go for critical emergency, it might take 1 or 2 weeks, but we will choose always the best session that you will have benefit. نحن كمان إذا بتشوفوا نحن رح نتكلم الحين نبلش بقصة البيزك ECG اللي هي it's very important for those who are working in a critical unit سواء كانوا بالعناية الفائقة أو بقسم الطوارئ أو بالدياليسيس أو pediatric ICU أو neonate ICU أو whatever كل اليونت ده يعني ممكن بتشوفوا على تخطيط القلب أو على ال ECG electrocardiogram. Okay, or what we call the electrocardiogram أو تخطيط القلب. نحن أنا just before starting I want to simplify it as much as I can لأنه نحن عندنا مشتركين ما عندهم critical care background ما عندهم emergency background بس أنا بحرص على إنه يطلعوا من هالسيشن إذا شافوا أي ECG على الأقل يعرفوا البيزك information if it's normal or abnormal or whatever. Okay? Sinus rhythm. رح بلشكم أول شيء بالsinus rhythm and I will go directly to the main point. طيب. First question. كيف بتقولوا عن شخص that he is today he is doing well or normal? For example, we are here 500% including me. How would you say that thanks God today I am okay? Based on what? Based on what? What are the criteria to say this person or this patient in my unit, regardless where is he, medical or surgical, how would you say that he is okay today? He is doing well. Based on what? Based on the vital signs, yes? يعني based on the vital signs or العلامات الحيوية بقول إنه this patient he is doing well. What are the vital signs? The blood pressure, temperature, the heart rate, the respiration, والpain. That's it. 5. Now, I could say I have a patient A and I have a patient B and B. Patient A, he is okay, doing well because temperature is okay, heart rate is okay, blood pressure is okay, and respiration is okay, there is no pain. This is the patient on bed 1, patient A. Patient bed B, he is not okay because he has a little bit temperature. فإذا المريض الأول أنا بقول he is 100% fit because there is no problem. المريض الثاني I won't say he is in critical condition لأنه عنده but he is not doing well لأنه عنده high temperature. المريض الثالث عنده tachycardia, hypotension. أنا بيصير في عندي doubt the patient he might go to ICU but still he is not in critical condition. المريض الرابع when عنده suddenly he is not responding, there is no heart rate, there is no blood pressure, no respiration, he passed away. فإذا نحن أنا في عندي components فمشان نقول إنه الشخص he is okay or no. This is the same applicable على ال ECG. كمان ال ECG we have components that it will show me that I am doing well, yes or no. اللي هن P, Q, R, S, T. احفظوا. نحن وقت بنحفظوا أعطيكم أول example عن النورمال بيرسون اللي هو heart rate, blood pressure, temperature, pain والrespiration. وأعطيتكم كيف أقول إنه الشخص normal or abnormal or he passed away. نفس الشيء it's applicable على ال ECG. ECG أنا في عندي components. إذا ال5 components موجودين وما في مشكل مثل أنا إذا بتاخذوا لي ال ECG أو أي شخص منكم الحمد لله اللي حيكون عندنا أنا 5 components are available no problem. وقت يكون عندي مشكلة ب 1 or 2 components I couldn't say that he has a normal ECG. وقت ال5 components مش موجودين يعني الشخص يعني كانوا بيقولوا عطاكم عمره توفى. What are the components of the ECG? Please look carefully on the below image here and to see. Let's say first component are the P. شفتوا ال P هنا واضحة؟ Q R S T واضحة؟ P لازم تتابعوا معي على الصورة عشان تفهموها، اوكي؟ P Q R S T P Q R S T P Q R S T P Q R S T. شفتوا هيدي بقول انه انا هون كل شيء موجوده الفايف كومبوننتس. كمان نحن هذا اول شيء، فاذا النظره الاولى بالوهله الاولى انا بشوف انه كل الكومبوننتس موجودين. شو الاشياء اللي بتبين انه ابنورمال؟ اول شغله اذا بتشوفوا الريت، نحن قديش الهارت ريت تبع المريض العادي؟ يعني قديش الهارت ريت تبعي؟ لازم تكون فوق 60 to 100 مضبوط؟ 60 to 100. اذا كان عندي more than 100 شو بنسميها؟ إذا الهارت ريت more than 100 what do you call it؟ bradycardia. سوري tachycardia. وإذا كانت less than 60 bradycardia. فإذا أنا كيف بعرف إذا كيف بتكون reflected if it's tachycardia or bradycardia؟ Here. بنصير نعد اللاينز. إذا بتشوفوها كثير قريبة على بعضها وقت بالإمرجنسي أنا ما عندي وقت أقدر أعدها باليد والهذا بتشوفها من خلال النظر. مشان هيك أنا بشوفهم. إذا كان الموضوع هو براديكارديا رح تشوفوها الآر هم بنسميه قلنا بي كيو آر، رح تشوفوا الآر على الآر هنا في مسافة بيناتها بعيدة عن بعض. إذا بتشوفوها تاكيكارديا فإذا بتكون الموضوع قريب، وإذا بتكون نورمال بتشوفوها اتس نورمال. هي أول أبنورماليتي. ثاني أبنورماليتي إحنا قلنا البي بنسمي هيدي البي ويفز. البي ويفز. This is how should looks. كمان في عندي أنا مسافة من هون من البي للآر لازم تكون 0.12 to 0.20 seconds and constant from beat to beat. يعني من هون لهون المسافة بدها تكون من 0.12 0.20 seconds. Again بالإمرجنسي أنا ما عندي وقت أقدر أعدهم بس بشوفها. إذا بتشوفوا هيدي it's too short يعني من هون ما في هيدي المسافة اللي هي 0.12 0.20 seconds. إذا ما بتشوفوا هيدي if you will not see this space here or it's too short or too long it's abnormal. Then the QRS here فإذا QRS it should be less than 0.10 seconds. If it's small you will see it's wide like this. You will see it during the day. Now we will be focusing only on the ECG, but you need to understand the concept or the basic, otherwise you cannot see the other things. Then, first of all, who could repeat what are the components of ECG that should be available? Can you tell me what are the components that, first of all, we need to make sure that they are available? Like what? PQRST, excellent. 5 points. Thank you, Khadija. فصلت اليوم 5 points. So many Khadija 5 points. PQRST. Remember the 5 points. Remember number 5. تذكروا لي رقم 5. 5. As a number 5 I have number 5. What I will move second? 2. What will be the second? As a number 5 it's done. أول خطوة. Now مثل ما بيقولوا نحن we are buying online نحن we purchase الitems. شفنا شو الitems موجودة. Duration of each segment. How to see the duration? Excellent. Our duration I will look after. It's the RR هنا. RR. How much should be the RR here? in order to say it's normal? How much should be the RR, the space? You say this is a normal RR and it's constant? No. I'm بحكيكم عن الRR. Less than 4 big square. يعني برجع بقول لكم in the ECG أنا I'm giving you hands on يعني ما عندنا وقت نعد. ال ECG course it might take 2 days if you're like RR بتشوفوه على النظر. You will see it by inspection. If you will see that the RR, let's say here, it start here and it's end here. Let's say the second R is here. إذا بتشوفوا هون second R, this is too short. This is means it's a tachycardia. Either the first R, it's here, and the second R is here. Look to the space. It's very long. This is a bradycardia. As I see the first time. Type RR here. I could see that it's for example, I have كل line نعده 10. 1, 2, 3, 4. يعني 1, 2, 3, 4, 5, 6. 6 by 10, it's 60. It should be 60 to 100 means it's normal. إذا طلع عندي أنا وين بلشت؟ R يعني 1, 10, 1, 2, 3, 4, 5, 6, 7, 8. 8, 9, 10, 11 ما كان في هيدي 110 يعني هيدي مش موجودة 110 it's 110 it's abnormal. إذا كان عندي 100 10 20 30 40 تاني R بلشت هنا شوفوا المسافة بين هون وهون it's a tachycardia. أخت فاطمة الار ار أنت الهات ريت تبعك لازم يكون من 60 لل 100 from 60 to 100. How it will be reflected on the ECG? You will count the line. يعني here you have this is the first line من هنا. كل line it will يعني equals of 10. كم عندي line هون؟ عندي 1 2 3 4 5 6. I have 6 line. 6 times 10 it's 60. 60 it's normal or abnormal? What do you think? 60 here. It's normal. Thank you. Now, إذا بياخدها من هون, forget about this. If you will count from 10, 20, 30, 40, 50, 60, 70, 80, 90, 20, 100, 100 from here to here. 100 it's normal or abnormal, or 110 it's abnormal. نبلش نحكي عن الراديكالي. فإذا this is هيك ال RR. طيب خلصت أنا إذا 5 components are available. ال RR it's okay. I will move to the PR interval. How much should be the PR interval? ليش لازم تكون ال PR interval? The P wave to the R. How much it should be? Three 0.12 to 0.20 seconds. Again, in a normal or in a critical condition, there is no way just to tell the patient, wait, I want to count. You will see it. The aim of this session is to teach you by inspection. بس من خلال النظر. لا عندنا وقت نقدر نعد ولا أي شيء. We want to see it by inspection. If you will inspect here, do you think based on the ECG here, the PR, do you think you could see it, it's a short, long, short يعني less than 0.12 seconds. Long, it's more than 0.1 seconds. Normal, it's between 0.12 and 0.20 seconds. How would you see here? Would you see it? It's short, long, or normal based on your inspection? How would you see it? It's normal. Thank you. It's normal, Anashif. It's normal. عظيم. فإذا you could see it as a normal طبيعي ما في أي مشكلة. طيب فإذا مثل ما حكينا بدنا نروح على الخطوات، نحن تذكر أنا بعطيكم الإكزامبل، أنا دائما شرح بحبه من خلال الإكزامبل، نحن بدنا نشتري ايتمز أونلاين، أول شغلة بدي I will order it, I will purchase, I will pay, they will send me the name, they will send me the code number, I will pay through the code and I will take the items. هون نفس الشيء، أول شيء بدي أطلع أنا على الكومبوننتس إذا موجودين QRST موجودين، عظيم. تروح على if there is something يعني طمنت على بالي إن it's normal. امتى بحس انه abnormal؟ وقتها بيكون رح تشوفوه خلال السيشن كامل وثلاث اليوم وبعد الظهر، انه بتشوفوا انه sometimes ما بيكونوا موجودين نهائيا، ساعتها انا بدي اروح على الشوك، بتعرف انت بتحط شوك والاخير. mainly هي مثل ما شايفين انه بما انه الخمس كومبوننتس موجودين بروح على تايمينج تبع الكومبوننتس، بشوف الار ار هل يا ترى بنورمال تاكيكارديا او براديكارديا، خلصت منها بروح على البي ار. البي ار انا بنشوفها اذا واسعه اذا قصيره او طويله. It's short or long. If it's between, no short, not long, I am doing well and it's okay. Now, رابع شغله تفوت علي اللي هي قصه الكيو ار اس. What do I need to see on the QRS؟ شو بتطلع على QRS؟ Wide or narrow? Excellent. It should be 0.10, less than 0.10 seconds. Again, you see by inspection. احفظوه. And this is a picture. هيك لازم تكون less than 0.10 seconds. إذا كانت وايد رح تشوفوها اليوم نهار رح يكون كثير على الاي سي جي، بتشوفوها انه من هون واسعه هيك. You see it on this way. This is abnormal. And this is what we call the basic components of the ECG. مفروض تكونوا حفظتوه لأنه ما فينا نروح على الشوكابل ريزم وعلى التاكيكارديا ريزم والبراديكارديا ريزم والاتريال ريزم والفنتريكولار ريزم إذا ما قدرتوا حفظتوا. هيدي بنسميها silent rhythm. This is my rhythm. Thanks God. الحمد لله. إذا بتاخذوا and this is your rhythm. Thanks God because now we are doing well. Clear? Any question about the sinus rhythm or that? This is what we call a sinus rhythm or normal rhythm or basic rhythm. It's okay. أي سؤال I am ready to answer. أنا إذا ما فهمتون أنا ما في يروح على السيشن تاني. It's clear. عظيم. Excellent. طيب. Now who want to witness and analyze this ECG؟ مين بيحب يعمل لي analyzing the ECG؟ لو سمحتم بالك بتروحوا على نفس الطريقة اللي علمتكم اياها. بهي تفضل. بهي. شوفي لي اللي فوق باللون الازرق. براديكارديا. ليش براديكارديا؟ بليز مثلا بتقولي لي هون براديكارديا بدك تشرحي لي ما يعني ما بتكتبوا كاتبي بلا شرح لانه انا بدي افهم. Now I want you to teach me 5R. يلا بليز. 5 by 10 50. What else؟ أول شغلة قبل ما تروحي على 5 by 10 شو بتطلع؟ P available, thank you. شايف ال P خدها هي. وعلينا RR it's normal, excellent. QRS موجودة. MT موجودة. عظيم. فإذا أول خطوة طلعنا عليها إنه أنا الكومبوننتس موجودة. Great. ثاني خطوة أخذ بها هي على شو بتطلع؟ Regular, thank you. يعني بتشوفوا إنه ال RR من هون لهون هي نفسها من هون لهون. نفس الشيء، نفس الشيء، نفس الشيء. إذا ال RR it's regular. طيب. PR interval. How would you see it? The PR interval. Normal. Excellent. إذا مش لاحظت إنه it's short or long. It's normal. Excellent. 0 لازم تكون 0.12 to 0.20 seconds. طيب بعد ال PR interval شو بتطلع؟ QRS ممتازة أخذ بهية. كمان نورمال. ليش حطيت لي نورمال؟ Why did you say that it's normal? Wide or normal? Why it's not wide مش واسع مظبوط؟ عظيم. فإذا this is a normal ECG. Okay? This is a normal, and everything is normal. The rate it's 60 RR. In 1, 2, 3, 4, 5, 6. 6 by 10 is a رح نشوف الحين نبلش بال another rhythm اللي هو فإذا this is a normal one. فإذا now بما إنه الكل شارك فيه I could say that this is a normal one. Now we will be talking about the another one. طيب رح نحكي الحين عن الساينس براديكارديا. فإذا أول شغلة اللي شفناها اللي هي it's a the normal one. رح نفوت الحين بالساينس براديكارديا. فإذا normal it's clear for everyone. The components RR it's constant. The PR it's within the normal range. The QRS within the normal range. Now I could move to the second one. رح نفوت الحين بالساينس براديكارديا. أنت بقول إنه المريض عنده ساينس براديكارديا. If the SA node discharge fewer than 60 millisievert per minute, the sinus is turned. وقت بكون عندي أنا ال RR أقل من 60 بس كل شيء نورمال. انتبهوا sinus rhythm or sinus bradycardia everything is normal باستثناء إنه ال RR هي تحت ال 60. وهون بنشوف المانجمنت بنشوف كيف نعمل المانجمنت. and present everything is normal and stuff. Who would like to analyze this rhythm? أنا نعمل analyzing of this rhythm. Who would like to analyze it? Step by step. ما بدنا معاكم إلا step by step. قبل ما تقولوا لي لأنه already أنا كتبت لكم ساينس براديكارديا واضحة. بس بعدين أنا بهمني تعرفوا step. Who would like to analyze this one? Step by step. عارفين إنه ساينس براديكارديا واضحة للكل، أوكي؟ بس أنا بدي أول شغلة شو بتطلع علي؟ أخذتي دورك أنت أخذ بهي، بدي حدا ثاني خلص. وش لك؟ أول شغلة رجعوا لي على البيزك اللي شرحت لكم. أول شغلة شكرا أخت شيماء. تفضلي. أول شغلة على شو بتطلع؟ لازم نعرفها بهالطريقة اللي هي الكومبوننتس. If the components are available or not. أخت شيماء would you see the components؟ شايفين الكومبوننتس هنا بالECG؟ خلونا على الكومبوننتس لو سمحتم. ما بدي في كثير ناس ممكن يكونوا يعرفوا ناس ما بيعرفوا. أنا بهمني اطلعوا مع السيشن ال 500 شخص كلها عارف نفس الشيء، ما بدنا نصدق بعضنا. روحوا لي على الكومبوننتس، موجودين ولا لا؟ ثانك يو ثانك يو. بي كيو ار اس تي موجودين. هيدي البي وهيدي الكيو وهيدي الار وهيدي الاس وهيدي التي. بي كيو ار اس تي بي كيو ار اس تي بي كيو ار اس تي بي كيو. عظيم. اول خطوه بنقول انه كل شيء موجود، ما في اي مشكله. بنروح على الحين انا نقيت الايتمز اونلاين، نقيت 5 ايتمز موجودين. بدي اروح على الخطوه الثانيه اللي هي I need to pay. طيب تفضلوا هنا خبروني الخطوه الثانيه شو هي؟ قبل البي الخطوه الثانيه شو هي؟ RR تصنيم RR. Well, how would you see the RR? Regular or irregular? My first question, it's regular or irregular? Regular, thank you. هلا ليش regular؟ لأنه بنشوف من هون المسافة من هون لهون هي نفسها من هون لهون، هي نفسها من هون لهون، هي نفسها. طيب قديش طلع معكم ال RR؟ It's regular, yes. Regular، ما في مشكلة بس عدوا لي اياهم، قديش طلعت معكم؟ 50 bits. فإذا this is how much PRR. فإذا this is تحسوها انه it's long. برجع بقول لكم نحن بالاكزام انا ما عندي وقت اقدر اعد البوكسز، انسوا قصه عد البوكسز هلا. فبك هيك بدك تضطروا تروحوا على كورس مثل ما هو يومين اي سي جي. نحن بدي اعلمكم باي انسبكشن، اي سي جي باي انسبكشن. انا لاحظت انه الار ار واسع، مش شورت، مش نورمال. تقول 1 2 3 4 5. لو نورمال it should be here هون it's a normal. بس بما انه it's more than here I could say that this is the heart rate, it's a prolonged RR. ساعتها اقول this is a bradycardia. لانه ليه؟ لانه هي اقل من 60 اللي هي 50. فاذا عندي طيب فاذا لاحظت هلا باين معي انا انه عندي ال RR it's normal, it's regular but it's not normal. باينت عندي it's a bradycardia. ال RR هي اقل هي اقل من 60 اللي طلعت معي 50 سكور. طيب برجع بتطلع الكومبوننتس السيري شو بتطلع عليها اللي هي بي ار. Do you think it's normal? How would you see it? The PR interval. It's normal. Thank you, Fatima. It's normal. فإذا والكومبوننتس الرابعة والأخيرة شو بتطلع عليهم؟ آخر كومبوننت QRS. It's normal. Thank you. منا it's not one. فإذا لحظة هلا شو بين هيك أختصر؟ PQRST are available. The PQRST are available. First of all. Second, بروح على ال RR. RR it's regular but it's not normal لأنه بين عندي أقل من 60 اللي هي 50. PR ال PR it's normal 0.12 to 0.1 seconds. ال PR it's normal وعندي ال QRS it's not كمان normal less than. فإذا كل شيء normal باستثناء فرق شغلة إنه الريت is less than 60. This is what we call it now a sinus bradycardia. وضحت كل شيء نورمال الريت اقل من 60. فاذا انا يعني sinus bradycardia everything is normal. This is what we call it sinus bradycardia. Clear? Do you want me to repeat it? Awesome. I'm very happy because you understand everything. أنا كثير مبسوط لأنه الحمد لله الكل يعني موضوع واضح بالنسبة للكل. الهارت ريت هاو تو كالكوليت بدك تعدي السكوير اللي هنا بين هون وهون، بس برجع بقول لك نحن بالحيط الكل هيك ما فيك يو كانت ما فيك يعني ما فيك يعني قد بدك تشوفيه من خلال النظر. هون النظر بينت انه الار ار واسع. اذا بدها تكون هون 10 20 30 40 50 or 60 هون بدها تكون تنقول انها نورمال، بينما هون اتس نوت لانه اوسع من هيك. ليش مريض بيصير في عنده ساينس براديكارديا؟ شو السبب؟ ام اي، هايبوكسيا، هايبوثيرميا، hypothyroidism, electrolytes imbalance, and medication. بعض الميديكيشن ممكن يسموا like ايه بيتا بلوكرز. فاذا نحن في عندنا اسباب بتخلي يصير في عنده المريض ساينس براديكارديا، اللي هي مثل ما حكينا اذا المريض عنده هايبوكسيا، عنده هايبوثيرميا، hypothyroidism, some of the medication and MI والى اخره. هذه الاشياء الكوزز اللي بتخلي المريض يصير في عنده. كيف المريض اذا نحن ان اديشن نحن دائما ما بناخذ الاي سي جي از سيبريت تمشي نقول ساينس براديكارديا. دائما المريض ممكن يكون بنسميها symptomatic or asymptomatic. symptomatic يعني بيكون عنده ECG abnormal in addition to the signs and symptoms which is abnormal. not symptomatic or asymptomatic بيكون just عنده اخذت الاي سي جي بين عنده ساينس براديكارديا بس ما عنده اي ساينز غير، بنسميها asymptomatic. فاذا دائما المريض and based on this we will treat. يعني اذا مريض حسب رايكم اذا اجاكم مريض واخذتوا له الاي سي جي وطلع ساينس براديكارديا بس ما عنده اي ساينز and symptoms what you will do؟ شو بنتصرف؟ إذا أخذتوا ECG لمريض sinus bradycardia but there is no other signs, what you will do? Follow up. Nothing. كيف nothing يعني؟ لا. Observe, close observation. We will keep the patient under close observation because at any time he might be symptomatic. يعني بأي وقت ممكن يكون المريض symptomatic. فإذا كيف المريض بعرف إنه symptomatic؟ يكون في عنده إجمالا براديكارديا، بيكون في عنده hypotension. He might have a chest pain, shortness of breathing, changes in the mental status, low urine output, and cold and deflamed skin. فإذا يجيكم مريض أخذتوا له الإي سي جي صار في عنده sinus bradycardia as isolated, no other symptoms. We will keep him under monitor and under observation because he might go to a sinus, he might go to symptomatic. But if the patient he has a bradycardia, sinus bradycardia, and 1 or 2 or 3 or all the following signs and symptoms, we need to start the treatment. And the first line of treatment will be what? شو أول علاج المريض؟ What will be؟ قبل الأتروبين قبل الميديكيشن قبل كل شيء. Need monitoring? Yes. Resuscitation. Treat the cause. Thank you نوال. سبقتيني بثواني. Treat the cause. بدي أعرف شو السبب. إذا المريض عنده نتيجة shortness مثلا shortness of breathing. ليش بدي أعمل أنا treating الهايبوتنشن؟ ما في هايبوتنشن. لازم I need to treat the cause. بدي أعرف شو السبب. أول خطوة بالساينس براديكارديا is to treat the cause. بدي أعالج أنا السبب. ليش شو هو السبب اللي خلى المريض يصير في عنده ساينس براديكارديا؟ What will be now the treatment intervention what will be هي الاتروبين والبيسنج ترانسكوتينيوس بيش اللي بيصير فيه إنه المريض رح تشوفوها بالسيشن الجايين ما بعرف إذا فينا نخلصهم كلهم اليوم بس يعني اللي وقتها بيروح على درجة البلوك يعني البي ار بتصير تكبر بصير هالسيشن يمد البراديكارديا تمشي يختفي مع الوقت بيروح بنسميها البلوك. اوكي؟ إذا نحن البيسنج مش دائما على الساينس براديكارديا اجمالا وقتها بصير المريض على درجة البلوك او البيسنج او البيس ميكر المرضى اللي بتشوفوا انه بيحطوه ترانسبيس الدوبامين كمان في السيفير لو بلاد بريشر اند وقتها بصير مريض بصير عنده براديكارديا اند هايبوتنشن ساعتها بنروح على الدوبامين والابنفرين انفيوجن واذا صار في عنده وصل على درجه البلوك بنعطي البيسنج. This is the intervention that it needs to be taken for a patient with sinus bradycardia. Clear, and this is a great example. شوفوا هذا PQRST بيرجع بس كيف شايفينها انتم هون؟ وين الابنورمال؟ بدون ما تطلعوا على فايكم شو شايفين الابنورمال هون؟ شو شايفين المشكله هنا؟ Very clear مجرد ما تطلعوا علي بثواني بينت عندي شو المشكله هون؟ ليش براديكارديا؟ لانه الار شوفوا شو المسافه بين الار اذا نحن الحين ما بقى في نسوم تعدوا على الاصابع السكوير اذا بدي اعد لكم اياهم نشوفوا 1 2 3 4 5 6 7 8 9 إذا بتعدى بتشوفوا قديش بعيدة المسافة يعني هون عنده الهارت ريت أو حوالي 30 أو 40 أوكي around 30 or 40 which is واضحة ما في لزوم قاعد أنا بالإمرجنسي مش قاعد أنا أقول له give me 1 minute I want to count لا ما بعملها أنا خلص ورحت علي من الانسبكشن من نظر إنه المريض عنده 40 beats per minute which is a sinus bradycardia. طيب. Another rhythm which is the sinus tachycardia. Who would like to analyze it? هلا ما بقى في الموضوع نطول بالوقت لازم تعملوها بشكل اسرع لانه خلص الريزم اخذته البيزك. بدي حدا وزن 1 minute يقول لي شو المشكله هون. يعمل لي كويك انالايز بخلال الستيب اللي قلت لكم عنه يعني ما مضى معكم لما تقولوا لي ستيب. انا اهم شيء عندي ستيب وتقولوا لي شو بين عندكم على السريع. تاكيكارديا ليش تصميم ليش عظيم PQRST available. Rate close RR it's constant. أهم شيء تقولوا لي constant but شو المشكلة؟ It's very close to each other. Okay. Narrow RR. عظيم. What else؟ فإذا قلتوا لي على الcomponents والRR قلتوا لي it's constant but it's bits 130. Excellent. PR interval اتس ريجولار. عظيم. بعد في شغله ما تقول عنها هي كيو ار اس. كيف شايفين الكيو ار اس؟ يس كيو ار اس نورمال. فاذا شو باين عندي هون؟ everything is normal، كل شيء مضبوط باستثناء فرق شغله انه it's around 100 120 or 120 to 130 which is abnormal بدون ما اعدل حتى ما في زوم عندهم. انا بهمني الار ار it's constant but it's very close to each other. هيدي sinus it's a sinus tachycardia. Otherwise everything is normal. كل شيء مضبوط باستثناء الريت it's very fast. عندي اياها around 120 to 130 which is a sinus tachycardia. عظيم. excellent. شو الكوز كمان؟ كل شيء مثل كل شيء على الاي سي جي بدي اعرف شو السبب وعالج السبب. واذا كانت just tachycardia ما في اي symptoms close observation. في symptoms بعالج السيمبتومز. شو هو السبب؟ يعني هون انا ليش المريض بصير في عنده ساينس تاكيكارديا؟ شو الكوز؟ بصير في عنده نتيجه فيفر بالاخص عند البيدياتريك، نتيجه البين انزايتي اذا اخذ كثير كافيين. مشان هيك انتم لما ياخذ كثير قهوه تذكروها، اللي كثير بياخذ قهوه بحس بيقول لك انا مع الوقت عم بحس دقات قلب سريعه. بس لانه الكافيين هي سبب للتاكيكارديا، بتعمل ساينس تاكيكارديا، بتعمل دقات قلب سريعه بالبيتيشن. مشان هيك اذا بتاخذ اي سي بتشوف انه ساينس تاكيكارديا. جاست وي نيد اذا بدي اعالج الموضوع شو بيقول لك الدكتور؟ خفف الكافيين، خلي ديكاف. مشان هيك في كثير من المحلات الحين بتشوفوا عم يعملوا ديكاف. ديكافين لانه الكافيين هو بيعمل دقات قلب سريعه. اذا راح المريض يعمل اي سي جي ببين عنده تاكيكارديا بس ما بكون عنده اي اذر ساينز اند سيمبتومز. وي نيد تو تريت ذا كوز. شو هو الكوز؟ خففوا القهوه شوي، ما تاخذوا اشياء كافيين. عشان you treat the cause. Now medication كمان some medication epinephrine. طيب نحن always we will treat فإذا based on the science and intervention مثل ما حكينا. always if there is science مع الساينس تاكيكارديا شو بنعمل؟ بنعمل fluid replacement, treat the pain and removal of offending medication or substances and reducing fever or anxiety. إذا نحن دائما بنعالج الكوز من خلال الفلويد مانجمنت. إذا كان نتيجة pain just treat the pain. نتيجة الكافيين stop الكافيين وإلى آخره and removal of offending medication or substances and reducing fever or anxiety. And هيدي is a clear picture about the ECG or the normal ECG or sorry tachycardia. طيب هون فاذا صرنا نعرف الساينس ريزم صرتوا تعرفوا اللي هو النورمال. في عندنا بيسمي ساينس تاكيكارديا وساينس براديكارديا. الريزم الرابع قبل ما نفوت بالاشياء الكريتيكال بالسيشن الثاني بدنا نشوف شو هو الساينس اريزمينس. شو هو الساينس اريزمينس؟ وشو المشكله بالساينس اريزمينس؟ نرجع كمان بليز جو باك تو ذا بيزك اللي هو الكومبوننتس. How would you analyze this rhythm? First of all, be present. Thank you. QRS present. Component is missing. شو الكومبوننت؟ شو الميسنج بالكومبوننتس؟ عظيم. بهالريزم انا شو لاحظت؟ شو ده؟ رجعوا لي على البيزك لو سمحت. نعرف شو المشكله. اول شيء خليني اشوف انا على الكومبوننتس. PQRST 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 PQRST. فاذا انا اول شيء الكومبوننتس موجوده. خلصت من اول خطوه، بدي اروح على الخطوه الثانيه، بدي اشوف الار ار. الار ار مثل ما انا شايفه انا based on my inspection 1 2 3 4 5 6 around 50 60 I could see it's a normal. بس انا اذا بدي اشوف شو باين عندي هون regular 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 irregular regular. شو صار عندي؟ شو المشكله عندنا هون بالار ار؟ ما في يقول انه it's regular it's irregular. عظيم. البي ار normal 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 حتى وقت كانت متابعه اللي هون it's normal. الكيو ار اس normal 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 حتى هون. بس انا شو باين عندي هون؟ وقت بحكي كلمه arrhythmias يعني something abnormal. اوكي. نحن اخذنا اول شيء اخذنا الساينس ريذم لانه كان كل شيء نورمال. هون اخذت ساينس اريزمياز لانه انا عندي بهودي اللي قلت لكم عنهم في عندي شغله بكل الكومبوننتس مش نورمال اللي هي الار ار. صحيح البي كيو ار اس موجوده وحتى وصحيح انه لا في لا تاكيكارديا ولا براديكارديا، بس انا باين عندي وحده من الريزم تشيز اتس irregular. شو بنسميها بساعتها هيدي الار ار اتس irregular بنسميها ساينس اريزمياز. ليش؟ لانه باين عندي وقت بيبين عندي وحده من الكومبوننتس مش مضبوطه حتى لو ما كان في اي علامات وكل شيء نورمال بنسميها اريزمياز. ساينس اريزمياز لنا تاكيكارديا ولنا براديكارديا ولنا نورمال ساينس ريزم انه الار ار اتس نوت irregular بنسميها ساينس اريزمياز. ساينس اريزمياز everything is normal unless the RR is abnormal. الكوز اجمالا بيكون associated with phase of respiration. بدرجه بيكون في phase of respiration بتصير في عندي هيدي المعادله. اكثر شيء بتصير عند بيكون عندهم مشاكل بالتنفس اكثر بتصير عند الانفانت والتشيلدرن او بيكون عندهم heart disease or increase intracranial pressure. الانترفنشن in case of التاكيكارديا وبراديكارديا في intervention if it's symptomatic لانه بتكون اذا asymptomatic closed observation. Here الاريزمياز no intervention mainly unless يعني اذا كان في لحظه مع شيء نوع من البراديكارديا او البراديكارديا. وضحت الساينس اريزميا؟ طيب فاذا نحن بنكون اخذنا النورمال ساينس ريزم، ساينس براديكارديا، ساينس تاكيكارديا اند ساينس اريزميا. هودي هن البيزك. هلا ليتر اون نحن بنبلش نشوف الاشياء بتصير مور ابنورمال. يعني بتشوفوا انتم بعدين بتشوفوا بريزم انه البي ما بتعرف مبين نهائيا الكيو ار اس وايد، بتشوفوا الكيو ار اس مش موجود نهائيا. ساعتها انا اي نيد تو جو في شوك. هلا حنشوف نحن الشوك ريزم والنون شوك ريزم والتاكيكارديا لانه التاكيكارديا بيتفرع من السوبرافنتريكولار تاكيكارديا والبراديكارديا. بس بيهمني خلال السيشن انه اخذت البيزك. If you have any question I will give you 2 minutes to answer your question before going for the morning break. أنا صراحة هول التو سيشن بالفاب والاكس جي كانوا جدا دسمين. أنا بعرف إنه now you need a coffee. طيب Okay, if there is no question, this is a time for a break. Take your breakfast, take your morning coffee and we will see you at 10:30 على الساعة 10:30 إن شاء الله بنكون مع القسم الثاني قبل يعني تبع فترة الصباح. Okay, فإذا take your break now, take your coffee and I will see you at around 10:30 إن شاء الله. Thank you for your attendance. شكرا لحضوركم وشكرا على الكولابوريشن وتعاونكم معنا.
for him, okay, this is exactly as you are giving him a bee sting, and he will have allergy. So make sure that before you do this, you make sure that the patient is not allergic to the bee sting. How to do it? Now, the appropriate site selection involves essentially any area where the skin and subcutaneous tissue can be pinched. So choose an area where you can pinch the skin, optimally between the scapula, and prefer the site of scheduling for several reasons. So why we said, scapula? So you're looking for many other, advantage when you're looking to the site. Like when you put an IV for pediatric, you make sure that, the site is not in a joint, not in a place where it can be infiltrated, can be migrated easily. So you're looking for a stable site, especially with pediatric, because they're moving a lot. They are not like adult. Okay, so you try to find a place where you can, is not in a joint, is not moving too much, where it can be secured and be safe. So the preferred site is between the two scapulas. First, it's out of sight, out of mind. The pediatric, the kid, the child will not be able to see it, so he will not think about it. To provide more diffuse subcutaneous area than other locations, so we have more subcutaneous tissue there, so fluid can be absorbed easier. Parent, and that's one of the most important things when talking about, pediatric patients from 1 to 3, they need their caregiver, they need to be feel like, their psychosocial, needs are, met in the emergency department. They usually need to be hugged. They need to be, feeling that they are in the lap of their parents and they're well taken care of. So parents can hold the child during the insertion. There's no need for restraint to restrain that. The area is less sensitive for pain than the other areas. These are the main, reasons why you choose the area between the two scapulas. As you can see in the picture here, the nurse is pinching the skin here for the pediatric. So you're going to choose a 25 gauge butterfly needle or 24 gauge catheter. If you don't have a needle that is, you can use the butterfly, okay? Otherwise, you can use 24 gauge catheter, the shortest one. The insertion device and the connection tubing should be gently flushed with 1 ml, as we said, 150 of hyaluronase with the skin and subcutaneous tissue pinch. One should insert the needle quickly into the pinched skin at 20 to 30 degree angle. So it involves two nurses at the same time. One is pinching the skin, okay, holding the baby, and the other one will insert the cannula in a 30 degree. If a blood retain occurs, the needle should be removed and choose another site, because direct contact with the blood will inactivate the enzyme. That's very important to remember. If there's a direct, contact with the blood, this will inactivate the enzyme. You can see in the picture here, this is between the two scapula for this kid. Brand new tubing subcutaneous needle with order dose of 200 hyaluronase and prep the skin for needle insertion. Pinch the skin between the two fingers. Insert subcutaneous needle at 90 degree angle until flush with the skin. Secure the transparent dressing, and you can see this one here with the draw syringe slightly to ensure there is no blood retain. Start the subcutaneous rehydration therapy. Begin subcu fluid administration via infusion pump. Okay, normal saline, continuous IV fluid can be given. Dextrose water, have normal saline can be given. Start at 25% order rate. So if the air order is 100, you can start, 25 cc. Increase 25% every 5 minutes. Full rate after 15 minutes. after beginning. Expect slightly redness. You can see the redness here. You can see the redness here. Fist size lip at infusion site for first 5 minutes after initiation. It's going to be painless. Swelling will soften to approximately 3 to 5 inches and resolve soon after completion. So it is okay to see this, at the beginning, you will see this. It's okay to see the redness, a small bulging over the skin here, but this is painless and this will go away. Document the site Q1 hour, change the site Q 24 hours to 48 hours. As we said, the hyaluronic acid, effect or the medication that you give subcutaneously to the baby, it will, terminate it after 24 hours. That's why you need to change the site and inject a new 1 ml. So this will help to absorb the fluid. If clinically indicated for the site condition and or following 1.5 to 2 liter fluid administered. So you can go up to 1.5. Obtain vital signs, assess fluid status baseline after each bolus administration. Provider will reassess after each bolus and or 24 hours for continuous infusion and place a new sub-Q order if initiated. So the window is 24 hours. You need to reassess to make sure how is the fluid status, the hydration status for your baby, and change the site, okay, and inject new hyaluronic acid. This is, a study in 2013 compared subcutaneous fluid infusion with intravenous fluid infusion in children with difficult IV access. They found the mean time from order entry to subcutaneous fluid infusion to be 20 minutes. So this fluid start to kick in 20 minutes compared with the IV failed access group with an average infusion start after 1.5 hours. So you almost have, an hour and 20 minutes, between the two, therapies. The latter group eventually received subcutaneous fluid. And the one who were very difficult, that's very important. And the one who were very difficult, that took 1.5 hours, ended up having, subcutaneous therapy. بمعنى آخر بالعربي الناس اللي كانوا في الستدي كانوا المفروض انهم ما قدروا يدخلوا لهم اي في انتهوا انهم يدخلوا لهم ايش subcutaneous therapy again. The investigator also found shorter ED length to stay of subcutaneous group. In the same study, subgroup received subcutaneous fluid initially and later an IV. They found trend of uneased IV access after subcutaneous fluid therapy. And this is very important also, guys. Please look at this point. Once we start the subcutaneous therapy, hydration for a baby, this will improve his vascular, status, will improve his hydration status, and will make it easy to find later on an IV access for him. And that's one of the, a recommendation that, don't waste your time with the difficult access kids. Start the rehydration therapy. The rehydration therapy will improve the vascular, or the hydration status for the patient. And this will eventually improve, the poor access and make him an easy access where nurses can give the IV fluid, start a cannula IV for him. Much has been studied and written about the predictor of difficult IV access in children, the most often cited age. And this is, when you're looking for this, and Now, how many ml per kg per minute? You're gonna use the same formula that you are using for hydration with the maintenance of the fluid. The only thing is different. You're gonna at the beginning you start with a 25% of the the rate that you set. Then you can increase to reach to the optimal rate. That's one of the criteria that when you look into the difficult access, the most cited are age less than 3 years, weight less than 5 kg, prematurity, obesity, darker skin tones. Those are patients are difficult to be accessed. Okay, so the 3 main predictor score validated. So by the emergency medicine. Emergency medicine include the most practical universal feature is vein palpability, vein visibility, and patient age. These are the 3 predictors that you, yes, I agree, pediatrics, they are difficult. When they are sick, they are more difficult. So the predictors that you can use, if you can see a vein, you palpate the vein, the vein visible, is the patient age. Those are, in general, predictors for the nurse before, or the healthcare provider before they put IV. If they cannot see a vein, if he cannot, palpate a vein, the age less than 3 years or 2 years, weight is less than 5 kg, baby is premature, obese or chubby, dark skin tones, chronic diseases, genetic diseases, renal failure. This is make, the access very poor. Now, we're talking about medication. Medication also can be given also through the subcutaneous route. So selected medication can be given by subcutaneous, like we're talking about antibiotic, it can be given. We're talking about medication, pain medication, it can be given through the subcutaneous route. What if I don't have, I'm not sure, the fancy hydrogenase in your department, in your pharmacy, in your hospital? It is actually increasingly readily found and available in generic form. If you have it, please use it. It will make a believer out of you and others. Hypodermolysis will work without hydrogenase. The process of subcutaneous hydration just takes a lot longer to work. So if you don't have this medication, okay, the hyaluronidase, it will work, but it takes more time to be absorbed to the vascular compartment. How long can you leave the subcutaneous line in? The longest time for the subcutaneous line has been reported to be left in patient has been 48 hours. When the child was discharged from inpatient unit, reports of leaving subcutaneous line in geriatric patients for longer period have been published. In one study, the average duration of infusion was 15 days, with an average daily, volume of 1,161 per day. So this is a good news that we can keep it for a longer time. We can hydrate patient. It is widely used in a palliative care in geriatric patient where they can insert, subcutaneous IV fluid, subcutaneous medication can be given to help, minimize the pain for them. Can the fluid other than normal saline ringer lactate be administered? Fluid rather than normal saline or ringer can be administered. Any fluid that contains NS or LR is acceptable, as we said. Potassium with 20 milliequivalent KCl fluid, such D5 water is too hypotonic and may affect the sodium potassium bond mechanism, the osmolarity. That's essential to the diffusion to occur. So you need not that much, fluid that is low osmolarity. Try to get, the isotonic fluids that can be easily, infiltrated and goes to the vascular compartment. Is it painful? Nerve ending in the middle layer of the skin, which is pierced. Nerve fibers that run along the blood vessels make intravenous lines hurt more than with the insertion. So the pain with the IVs is more. With this method, the skin is pierced, but the needle goes into fat. So the needle is going in the fat subcutaneous tissue, whereas there are few or no nerve ending because we use very small needle. The pain with the pierce of the skin, which feel like a finger prick, but it's gone quickly. A topical anesthetic might be used, just to remove the pain. Some they use Imla cream or anything that could help to remove the pain. In summary, hyaluronidase augmented subcutaneous rehydration therapy. It's becoming an accepted alternative for children with mild moderate dehydration when oral hydration has failed and intravenous access is difficult in pediatric. While use a nasogastric tube is an accepted alternative, the technique is invasive and requires restraining of the child extremities and can lead to complication. And all of you know that, NG, even for adults, is very irritant and nobody can tolerate it. So imagine a 2 years child or 1 year and a half, and you start trying to put NG tube to give oral hydration, they will remove it. They cannot keep it, okay? But this kind of therapy is it's less painful. They don't feel the pain. It's one prick. There's no, you don't need to to make sure that you palpate, everything is visible. It's easy. You pinch the skin and you go to the subcutaneous tissue and you start your hydration. As we said in the study, it took, the average or the mean time is 20 minutes to start this hydration, while it may take, 2 hours to start, IV access for difficult or poor access kids. The use of oral ondansetron has enhanced oral hydration therapy, but is not always successful. And this is what we see in emergency. Yes, patient came with mild dehydration, moderate dehydration, a trial of ondansetron to be given. Sometimes it works, sometimes it doesn't work, and you ended up having the baby needs IV fluid. So if he's having a poor access, difficult access, the best way is to start, subcutaneous rehydration therapy. These are the references. If you have any question, please post them in the chat. I will open the next, topic. Okay, guys, I see no questions. So shall we move to the next topic? And thank you for your comment. I hope you guys, you can take this, and start implement it in your emergency department. It's very, very useful, and especially for the kid, for the nurses who's working with pediatric, they know how much they suffer with the IVs and how much they are difficult when it comes, they need IV therapy. Thank you to all of you, and we will move to the next topic. We'll talk about the chest tube and how to take care of patient who is in a chest tube, how to troubleshoot, what are the standard of care, or what are the guidelines, and what are the indication and complications of that. I guess these are our objective, is to know the indication, complications, standard of care, and the guidelines for taking care and nursing consideration for the chest tube. So we start with the chest anatomy. As all of you see the two lungs, and you can see, the visceral layer here, and you can see the parietal layer, and in between what we have, the pleural cavity. So we have the parietal pleura, outside membrane of the lung, the pulmonary or the visceral pleura. The two membranes are held together, separated by lubricating the pleural fluid. So in between the two layers, we have a pleural cavity, and the pleural cavity holds, fluids. And this is, the main the main purpose for that, these layers, they're gonna rub against each other. When they rub against each other, if there's no fluid, okay, they will, this is what we call it when you listen to the patient chest, we call it about friction rub. The friction rub, sounds happens when there's no, fluid, because these lines, the two layers are rubbing against each other. So you want to prevent the friction. There should be a fluid there, and the fluid will help, the elasticity for the lung, to move and expand easier when they rub against each other. Now, lung can expand and contract easier, and that's why, most of the time when we talk about, patients who are on ventilator and they want to assess their lung function, their compliance, and how much, this lung can expand. This is depends, about, the layers and how much fluid in the layers. So normally a negative pressure in the pleural space keeps, the two pleural together. If fluid or air enters, the pleural space, lung cannot fully expand. Just to make it easy, as you know, all of how we breathe, that, we have the atmospheric pressure outside. We have inside the alveoli the intra-alveolar pressure, and we have intrapleural pressure. Now, inside we have the pressure, and with the intra-alveolar pressure are almost the same. Here they have the pressure is a -4 from the atmospheric pressure. So that means the pressure is here will be -4 to -8. It depends with the inhalation and exhalation when the patient takes a breath. So we always have a negative pressure resulting from, moving air inside the lung, changing the volume, and changing the pressure will end up that have a negative pressure here. So this is the normal mechanism when the patient. Yeah, Hannah, go ahead and pose your question for the coordinators. So the chest wall composed of ribs, sternum, thoracic vertebra, and interlaced with intercostal muscles. The diaphragm is the floor, and the diaphragm is here of the thoracic cavity and plays key in role of mechanics of breathing. And this is what we call about, when we breathe, mainly the contraction and relaxation of the diaphragm will help, change the volume and the pressure. When the pressure changes, air can flow from the higher area, which is the atmospheric, inside the intrapulmonary or intra-alveolar. And once the volume inside the intra or alveoli became, higher than the pressure outside, air will flow from the higher to the lower. with the help of the negative pressure that in the pleural cavity. Now, during inhalation, the diaphragm contracts down. As all of you see, it's going down, and air into the trachea, bronchi, bronchioles, and alveoli. The reason for that, the reason for that, there is always a inverse relationship between the volume and the pressure. So when the diaphragm, contracts and move down, that means I'm increasing the volume. What will happen to the intrapulmonary pressure? Intrapulmonary pressure or intraalveolar pressure, name it the way you like, but it is, again, it's the pressure inside the lung. When the volume increases, the pressure decreases. So the normal atmospheric pressure is 760 millimeter mercury. The intrapulmonary pressure is 760 millimeter mercury. The intrapleural pressure is 756 millimeter mercury. So there is a 5, millimeter mercury difference between pulmonary, intrapulmonary, and atmospheric pressure. So when the patient, take a breath, the contraction of the diaphragm will increase the volume of the lung. Increases the volume, that means decreasing the pressure. So the pressure of the intrapulmonary, intraalveolar will decrease about 1 to 2 millimeter per mercury. This will allow air to escape inside the lung or gets inside the lung. At the same time, the pressure will be negative in the pleural because it is -4. It can be, up to -6 to -8 millimeter centimeter water. Lung capacity enlarged, intrapulmonary pressure becomes lower than the atmospheric pressure. The air is pulled into the lung, and this is the mechanism how we breathe and how the air can, gets inside our lung. Now, during exhalation, the diaphragm relaxes. What happens in it's the opposite. Okay, now with the exhalation, diaphragm gets relaxed, volume decreased, pressure increased, and we have pressure intrapulmonary is higher than the pressure in the atmospheric pressure, and this will help in the air to force out the lung. And this is a passive, operation is so why we need a chest tube? If flexible, first let's talk about the chest tube and what it is. Flexible chest tube inserted through the side of the chest and in the pleural space. Use the drain contents from intrathoracic space. Tubes are connected to chest drainage system. I think most of you have seen the chest tube. And the chest tube drainage system, you have a canisters typically collect, chest tube contents, air, blood, and effusion. So the collection chamber that you have in the chest tube is to collect whether a patient have a hemothorax or a chylothorax, or they have, pneumothorax, or if they have a pleural effusion. And all types of this, there's whether there's an air in the pleural cavity, whether there's an pleural fluid in the fluid pus or fluid or any kind of fluid that can be in this pleural cavity, it has to be removed, and chest tube is one of the modalities that can be inserted to remove this. It can hold up to 2,000 ml of fluid. Typically, there are 3 chambers. One is your drainage chamber or a collection chamber, the water seal chamber, and the suction control chamber. All of you have seen, the chest tube with the 3 chambers together. Not the old one, the 3 bottles. Now they have them all together. Have you seen this chest tube? Any answer, guys? You hear me? Okay, so some of you, yes, familiar, you are familiar with this. Ahmed, Anna, excellent. Excellent. Excellent, guys. So it can be connected to suction, or it can be used, it can be, a dry, or it can be a wet, chest tube. Need to stay below the level of the patient chest always. So what are the indication? The indication is, as we said, mentioned, a pneumothorax, okay? When the air leaks the lung into the chest, a pneumothorax, or after surgery, bleeding to the chest. We'll have a lot of trauma patients who have a pneumothorax, flyal chest, okay, collection of fat, okay, chylothorax, empyema, or pleural effusion. Many patients, cancer patients, they ended up having the pleural fluid sneaking onto the lung. Just let me go back to the previous slide. As you see here in the pleural cavity, guys, here, there is a small drainage to the fluid that can be out, because the fluid are maintained in a certain range inside the pleural cavity. When the fluid, became above the level, there's a lymphatic system here where the tube can drain. It's not showing in the picture, and what happens, patients who are having a cancer, patients, they ended up having the fluid coming from the lymphatic system into the pleural cavity and having pleural effusion. And you've seen many of them, they will have 1 liter, 2 liter of, effusion inside the pleural cavity. Where this fluid comes from the lymphatic system, and it went to the pleural cavity. Let's take them one by one to talk about the pneumothorax, where an air, enter inside the pleural cavity of the chest between the lung and the chest wall. And as you can see, this poor right lung, how it became, smaller in size, okay, and being pushed away to the left side. And the reason for that, because there's an air in this area. Air have entered through whether a trauma, whether, spontaneous pneumothorax, whether after surgery, but in all cases, air ended up building up in this area and keep pushing, the lung to the left side, and having patient, became very sick and having distributive shock. A hemothorax, it could be a condition where result from blood accumulating in the pleural cavity. How does this happen? Pulmonary contusion, okay, can cause, especially with a trauma patient, can cause accumulating of blood. Chylothorax, also a type of pleural effusion resulting from lymphatic fluid, as we said, chyle accumulating in the pleural cavity. As we said, it is, infiltrating, sneaking from the lymphatic system inside the pleural cavity. And empyema is a collection of pus within the naturally existing anatomical, cavity, such as the lung pleura. So this is, empyema, and it's a natural, pus happening because of infection, lung abscesses, it happens sometimes with a cystic fibrosis patients. All those patients, they develop, some lung abscesses. The plastic multi-chamber, you have seen this, it has, the 3-chamber, the suction chamber, water seal chamber, and the drainage collection chamber. These are, 3 chambers, okay, separate chambers, drainage collection, and you can see the water seal chamber and the suction chamber. So the water seal chamber is here. This is air leak detector, and this is the suction, and here's you have your drainage or collection chamber. Now, once the physician decided to insert a chest tube for your patient example for pleural effusion or for hemothorax or for chylothorax, remember for that, if they inserted the tube right away and you're having more than 100 ml per hour, you should not have large amount of blood discharge. This tube has to be, maybe speak to the physician, maybe it need to be clamped every now and then to make sure that the patient will not have a shock. There's, when the lung, all of a sudden expanded after a long period of time where it's been, shrinking, and you remove the fluid, all of a sudden, first the patient will have, shock, become hypertensive. The second thing, you may have something called re-expansion pulmonary edema. The fluid that been, removed, all of a sudden, it will, get fluid sneak from the inside to the alveoli and causing pulmonary edema. So these are one of the, that's why, it comes, if you see more than 100 ml per hour, this is a warning sign. In pediatric, should not take 10 ml per kg per hour. The water seal chamber, or air leak detector should have intermittent bubbling. It is expected to have at the beginning, normal bubbling because you inserted, the tube, especially with the pneumothorax. You expect to see that, but later on, it is not, expected to see, excessive bubbling inside the water seal chamber. Should have been, soft tailing, if not hooked up to the wall suction. Now, if you hooked it up to the wall suction, you will not be able to see, the bubbling or the tailing, because it's going to be continuously bubbling and excessively because of the suction if you connect it to the wall suction. As we said, we shouldn't have, excessive amount of bubbling. It is expected at the beginning, especially if you have a pneumothorax or a huge pneumothorax, to see excessive bubbling at the beginning insertion, but later on, it should be a normal tailing, a normal, soft bubbling with breathing in and breathing out. Come to the suction control chamber. This should be a continuous gentle bubbling if hooked to the wall suction, and should have been, between minus 20 centimeter of water, and shouldn't be and have excessive bubbling. Why we shouldn't have excessive bubbling for that? Why we should not turn it to like 200 or 300 millimeter mercury in the wall suction? Any idea? So this is the suction chamber. We fill it up to 20, in adult up to 15 to 20, minus 15 to 20 centimeter water. In pediatric, we will fill it 10 to 15 centimeter minus 10 to 15 centimeter water. And we hooked it to suction. And now suction should be 80 to 120. Why we should not put in a high flow suction? Okay, Ahmed. Why we should not put in a high flow suction? Now, just let me put it in this way. Now, if you put it in a high, like a 300, or you put it in 100 or in 80, there's no difference. The one who controls the suction is the suction chamber, because you set it up to minus 20 centimeter mercury. Over evacuation, no, this one will not cause, but what can damage the tissue? No, because what you are looking here is your suction is being put to certain level of pressure. The reason for that, is here the one who control the suction is the level of the water you have added. So this one have the minus 20 centimeter water this is your suction setup. The water will help, when you put it to the water, not to do excessive bubbling, but because if there's an excessive bubbling, there will be an evaporation. When the evaporation happens to the water, that means the level of the pressure that you have set, which is minus 20, will flow that minus 20. Are we clear about this? So the over, suctioning will cause evaporation. The evaporation ended up, bringing your level of pressure below the one that you set up to minus 20. Are we clear? Is it clear for you guys? Excellent. Now I hope this video will over. Guys, this is how does the chest tube, and this is your collection chamber. This is the base of your chest drain, okay? This is the funnel shape. The funnel shape meant to have, exactly if you fill it up to here, it will fill up to 2 centimeters, exactly. Now, will work as a one-way valve, will prevent, air from coming back to the lung, will help the air, to drain out of the lung. You close it, you fill it here, then you open it, you will have exactly the 2 centimeter level here. And you can see fill it with the water, and you will have it exactly up to 2 centimeter. The 2 centimeter level, okay, will work as one-way valve, will prevent air coming back to the lung, will allow air only to escape. This, okay, this can be up to suction. Then you can fill your suction part, the suction chamber with the water, as we set up to minus 20. Okay, Hanan will answer you in a minute. So you keep filling up to, this is a minus 15, and this is a minus 20. We might have another kind where you can see the dry system of the chest tube. And you see the same thing, they're filling the water. And give you exactly. So they work the same principle. Okay, Hanan asked about, how do we check for a leak from the chest tube? So first, as we said, go to the air leak chamber, which is the 2 centimeters there, and you see the tailing of the fluid there, the water. If you see excessive bubbling, you will expect that the patient having some air leak. And you start, looking from the point of origin of the chest tube with the clamp. And this is one of the, the times that you are, guys, you hear the voice, the sound. Okay, so these are one of the times that you assist, you allow to use the clamping in the chest tube. So one of the times that allowed is to check is when you are detecting for air leak. And once you see an excessive bubbling, you start with the clamp from the top, from the insertion side, and you clamp. You keep going until you see that, the bubbling, the excessive bubbling stopped. And from there, you can know from, is it from up to the insertion side? Is it from the tube? Is it from the same, kit itself? Maybe it need to be changed. So you're gonna assess all of that. We'll go in that in deep. Now, air leak in the water seat chamber, assess patient. Clamp the tube less than 1 minute near to the insertion site, okay? If bubbling stops, air leak is above the clamp, okay? Clamp the tube and apply petroleum grease dressing, notify the MD because it's near the insertion site. If bubbling does not stop, you keep going with your move clamping along the tubing towards the pleural evac and monitor cessation of bubbling. When bubbling stops, see the site of leakage. If it reaches to the pleural evac and bubbling has not stopped, change the pleural. As we said, you may ended up having the whole drainage unit need to be changed. That's when we're looking for the air leak. We're talking about chest tube became disconnected. And that's why one of the emergencies that to have, a sterile water, okay, to be ready, a bottle of sterile water to be ready at the patient bedside in case of the chest tube disconnected. So it is not dislodged, it's only disconnected. So the disconnected between the tube and the drainage unit. Now, if this happens, you insert the tube in the sterile water bottle down to 2 centimeters, just to make, a negative pressure and will not allow air to escape back again to the lung. Make sure that you have a bottle of sterile water on the patient at the bedside all the time. And you have also a clamp ready in case if you need to clamp. Stay with the patient until another nurse prepares a new drainage kit where you can opt it or connect it again. Now, what we will do if the chest tube is totally dislodged and came out? Have the patient to push a quick exhale and take deep breath and hold. You ask the patient to take a deep breath and hold. Cover the site from the 3 occlusive dressing sites and leave one side just to make a one-way valve, the same principle as you said. We want air not to come back to the lung. We want air to go outside of the lung. Stay with the patient, inform the doctor right away so they can come and insert and manage the patient. If there is a subcutaneous emphysema, which is sometimes very common after chest tube, okay, present after the chest tube insertion, immediately inform the physician. It may indicate an air leak. Sometimes there will be an air leak from the tube, and sometimes their thoracic surgeon, they're aware of that, and they will keep observing the patient, okay? If the emphysema is present emphysema, also immediately after the chest tube, you need to inform that sometimes there is a huge air leak at the insertion site that they need to be corrected by the thoracic surgeon. If the drainage unit is tipped over, flipped over, or filled, upright the unit immediately. So put the unit in a vertical position again. Ensure collect water seal level, because yes, we do have 4 chambers. They are separate chambers, but the fluid can migrate from chamber to another chamber. Okay, so make sure that the water seal level is 2 centimeters. It did not change, did not reduce, it did not increase, and make change to the drainage unit if needed. So if you see like blood or pleural effusion fluid filled inside the water, and you are not able to see if there's 2 centimeters, it's this will prevent the whole principal chest tube. Change the whole unit or the whole pleural back. What do you need to prepare before the procedure? You need to make sure the consent, site marking, check the patient, the physician privilege. Is the patient, privileged to do the procedure, especially when it comes, also with the pediatric patient, with patients who are very thin. Sometimes, it easily, you can puncture, the lung, you can puncture the liver. It depends who's doing the procedure. So look at the patient, how sick he is. Thin patients, pediatric patients are very critical when it comes to insertion of chest tube. Explain, prepare, get everything, and right away chest X-ray. For sure, there's X-ray has been done before the procedure, but after the tube insertion, there should be one, to see the site, is it in place, where the tube is located, and how much output. That's your documentation. The patency, the pain. Make sure also from the pain that you give the patient, one of the things that preventing patient, from exhaling the air is the pain. So if they have severe pain, they will not have a good, respiratory muscle. They will not have a good contraction and relaxation. Make sure that there is also physiotherapy. During the procedure, make sure that you maintain aseptic non-touch technique, sterile procedure, and one of the things we use also peer-to-peer review. So we make sure with the flow sheet that is the one who's doing the procedure is using a maximum barriers, sterile technique, and chest X-ray. What are the complications? Bleeding, sometimes PE, cardiac tamponade. It could happen atelectasis. Also, it could happen from the technique from insertion or post insertion, or if there is a damage or puncturing to the one of the organs, the lung or liver. This might be happening. What are emergency equipment need to be ready? Make sure that you have a sterile normal saline. Use if a tubing gets disconnected. Submerge the end of the chest tube to 1 to 2 inches, which we're looking for to 2 centimeters. And petroleum gauze used to cover the chest incision if the tube is accidentally removed. Allow air to escape from the incision and prevent air from coming back to the lung. Depending on the facility policy and procedure, or sometimes all 4 sides of the gauze can be taped down to the patient's skin. Now, questions like when are the times we can do clamping for the chest tube? Can you guys answer when are the times we do clamping for chest tube? Okay, when we are looking for detecting early, suspecting early, excellent, and before removing. So these are 2. Okay, what else? No air. I didn't get. When moving patient, no. Moving patient, transferring patient, transporting patient, we should not clamp the chest tube. Chest tube should be hooked to the bed below patient chest, okay, to go by gravity, but we don't clamp them. We clamp them when we are detecting for early. We clamp them when we are removing the chest tube. We clamp them when there's a doctor orders to clamp, and we clamp them when the chest tube get disconnected and we want to put them in the These are the times where we clamping the chest tube. If you have used the same brewer back, let me go back to the slide again. This one's okay, have a negative pressure valve at the back and positive pressure valve. So you may ask, sometimes yes, we get, pneumothorax. This is where the fluid gets collected, as blood. So what happens, where's the air goes when we collect for air? Where's the air, the air escapes through the positive pressure valve here. And there's a ball here that, you can see it, the tethering ball that, goes up with the inhalation and goes down with the exhalation for normal spontaneous breathing. When it comes for the ventilated patients, it is the other way with the positive, breathing, where the ball will go down with the inhalation and it will go up with the exhalation. Sometimes when there is extra pressure, okay, extra air, start to build up in the pleural cavity, you can see the ball is not moving here and stuck here. That means there's extra pressure inside, and you have to intervene to remove the pressure this manually. That's why you have a negative pressure valve. It could be at the back of here. You just press it. When you press it, you allow the air to expel and goes out, and this is will release the pressure in the lung. But make sure that you have your patient is hooked to suction. That are one of the thing, or the safety or the emergency button that you have it in the lower back when your patient needed, who have like spontaneous pneumothorax, or having sometimes, especially if your patient in a ventilator, and you will see that a lot when your patient in a ventilator, all of a sudden your patient became desatting, all of a sudden became hypotensive. This is because of the, whether have accumulation of, there's a barotrauma, accumulation of air that happens, and you need to use your negative pressure valve. Sometimes with the kinking, simple kinking in the tube will affect, and causing sudden, accumulation of air in the pleural cavity. You just make sure that the patient is not lying in the tube. There's no, that's why one of the things, the tube itself, there should now be lubing in the tube that will prevent, and may affect the flow, whether of air or pleural effusion or blood. Last thing, last we'll talk about sampling. The tube itself, that is from the chest tube to the pleural cavity to the system itself, it's a rubber, tubing. This tubing can be, taking sample. It's a self-healing rubber, so you can easily put a gauge 18 or 20 and take the sample if you want to take sample for pleural effusion and culture it or send it for chemistry or CBC. It can be easily sent through that, and the rubber is self-healing. That's mainly about, or there will be a three-way here where you can take your samples as well. Any questions about the chest tube? Okay, guys, if no question about the chest tube, you would go for a break, and we'll join again at 1 o'clock. Thank you very much. I think we're talking about the SA node, the AV node, the ventricular fiber, and normally these ventricles they generate impulses at rate of 20 to 40 beats per minute, and they're considered the least when it comes to the in comparison with the sinoatrial point, which is about 60 to 100. They are the least when it comes to as a pacemaker. So if a pacemaker fails, the natural pacemaker and the ventricle taking over from the atrium, the normal heart rate is going to be 20 to 40. And they might, this is a backup plan, which is for all our body, any system in our body does have a backup plan in case something did not work. God, give us a backup, and the backup for the conductivity system in our heart, from the SA node to AV node to the Purkinje fibers, So if SA node fails to discharge or to fire impulses, ventricle will take over and start to, however, ventricle will not do the same job as the atrium. And impulses, from the SA node is generated, but blocked is as its exit to the SA node. The rate of discharge of SA node is slower than, the ventricle. This is the times where, may assume responsibility of pacing the heart if SA node is failed discharge. Impulses from the SA node is generated but blocked. There's a pathway or the conductive pathway from SA node to AV node to the Purkinje file is blocked. This is the time. The rate of discharge of SA node is lower than the ventricles, which is 20 to 40. An irritable site in either ventricle produces an early beat or rapid rhythm. The ventricular debolarization beats or rhythm may originate from any part from the ventricles. In the ECG, we have the QRS, which is representing the ventricular debolarization, typically characterized by QRS, as mentioned. They are normally shaped, and they are 0.12 seconds. So they are 0.04 to 0.12 seconds. That's the normal, duration for the QRS during the cardiac cycle. Because of ventricle debolarization is abnormal, ventricle rebolarization also abnormal, resulting in ST segment and T wave that will be appearing in the ECG. And the T wave are usually in a direction opposite to the QRS complex, as we can all see in this figure. We start with the first rhythm, which is premature ventricular complex, or the BVCs. And many of us have seen ECGs, patients with BVCs. This is arise from an irritable focus within either, any site of the ventricle. And you can see here, this is the ventricle, the both ventricles. If there's any, firing that's happening from these sides, is premature, occurring earlier than the next expected sinus beat. So we are expecting this, the ventricle to fire at a certain time, and there's a beat, something happened earlier to the expected one. And typically, equal or greater than even the shape of this, BVCs, because it's premature, it will be different from the, in the normal shape, and it might be, longer duration, more than 0.12 seconds. And this BVC premature will depolarize ventricle. However, this is premature and in abnormal manner. The T wave usually in the opposite direction of the QRS, which is have no change in that. These BVCs can be pairs. Two happens, and we call them two sequential BVCs, couplets. Here we have runs of VT, and those are, sustained VT. Non-sustained VT will have them, three comes together and they disappear for ventricular tachycardia. If they are sustainable, they will be ventricular tachycardia. If they are, we call them non-sustainable VT. Bigeminal BVC and every other beat. So you will have this happening as every other beat, or they have been every third beat, we call them trigeminal. The quadrigeminal BVCs, these ventricular quadrigemini, it happens every fourth beat is there's a BVC. These are the patterns of the BVCs. And as you can see here in the ECG, some of them every 4, some of them every 3, some of them is, every 2. We call them bigemini, trigemini, quadrigemini. Uniform BVCs, premature ventricular beats that look the same in the same beat and originate from the same anatomical focus. So you look into the shape of these BVCs here, they are originating from the same focus. That's why they have the same anatomical shape in the ECG graph. When you have a multifocal BVCs, they are originating from, they are appears in, from different, from one to another in the same beat often, but not always. They are originating from different anatomical sites in the ventricle. Terminology, the term unifocal or multifocal are sometimes used to describe BVCs that are similar or different in appearance. Okay, if they are unifocal or multifocal. Uniformal BVCs are unifocal, but multiform BVCs are not necessarily multifocal. RONT BVCs, I think we mentioned this when we talk about the cardioversion and defibrillation, and when the R wave on BVCs fall on the T of the preceding beat. BVCs occurring during the period of the cardiac cycle may precipitate VTAC or VFib if this is happens. If the BVCs happens to the preceding beat at hit the T wave, it may change to VFib or VTAC. When you have a couplet where there's a pair of two BVCs or more occurring in immediate succession of a rate more than 100 minutes, okay, 100 beats per minute are called salvo or run or burst. Different terminologies can be used. Runs of VTAC, non-sustainable VTAC, name it the way you like it, but you can see you have 3 BVCs runs together, then you have 1 beat normal, then you have 2 runs of BVCs or paired BVCs. So what are the characteristics of the ECG when they have BVCs? Usually within normal range. Sometimes it does not get affected, but sometimes in the underlying rhythm maybe a little bit tachycardic. Essentially regular with premature beats, especially if they are not happening often. Yes, Majdi, any comment? The B wave usually absent or retrograde conduction to the atria may appear after QRS. Usually upright in the ST segment or in T wave. The BR interval, if you are trying to measure the BR interval, none of the BVCs, guys, give me a second, let me just check this. Continue, it's going to be greater than 0.12 seconds. It's going to be wide, and you can see the shape, okay, of the QRS. It's wide, bizarre T wave frequently in opposite direction of the QRS. What are the causes? What causes BVCs to happen? Actually, in most of the time, is not something that could be avoided. And so sometimes it happens in a healthy person with apparently normal heart with no apparent cause, and sometimes incident of BVCs increase with the age. But it could be also to other conditions. Sometimes, exercise, digitalis toxicity, stress anxiety, hypoxia, acid-base imbalance, electrolyte imbalance. Frequently we see it, sometimes with the hypokalemia, hypocalcemia, hypomagnesemia, hypocalcemia, hyper and hypo. People who's taking, too much coffee, alcohol, tobacco, they might have in their ECG or their P, sometimes it's BVCs. Medication, sympathomotic medication, cyclic antidepressant patients, and phentothioxines. MI patients, increased sympathetic tone, congestive heart failure, frequently have, these rhythms where they have, frequent BVCs. May not produce, palpable pulses. Patient may asymptomatic or complain of racing heart, feeling that their heart is, beating too fast, skip beats, or feeling, there's missing beats. Sometimes chest discomfort. BVCs are frequent, and signs of cardiac output may be, maybe change or maybe affected. This is the time where treatment has to start. And first of all, treat the underlying cause. If the cause is taking too much alcohol or coffee or stimulant, if it's medication wise, if it is electrolyte imbalance, the cause has to be corrected before. And look to the patient's signs and symptoms. But most of the time, patients experience BVC, they don't require treatment with antihistaminic medication. So most, I would say, majority of patients, they don't require any type of, cardiac medication, antiarrhythmic medication. The other type of ventricular dysrhythmia, atrioventricular rhythm, or a ventricular escape atrioventricular rhythm, is a 3 or more secretional ventricular escape beats occurring at a rate of 20 to 40. And you can see the patient is bradycardia, and you have 3, atrioventricular rhythm, 3 more ventricular escape beats occurring with a lower rate. May occur when the SA node and the AV node junction fail. So this is the time another backup, mechanism happen in our body. AV node, SA node failed, AV node failed. Now they come up with a third backup where the peritoneal fibers start to take over, and the rate is going to be very slow, 20 to 40. Impulses generated by supraventricular side are blocked. May also occur because of myocardial infarction, digitalis toxicity, and metabolic imbalances as well. So you may see this rhythm with the patient who has, acute myocardial infarction or taking digoxin. Now, because the rate is very low, cardiac output might be affected. Patient will be symptomatic, severe hypotension, weakness, disorientation, decreased level of consciousness, color will be pale, will be cold, pulses are weak, and blood pressure will be affected. And for sure, the brain will get affected, loss of consciousness and drowsiness also happen. This is not something that can be left, it needs to be treated, and the treatment always is to maintain heart rate and cardiac output. How do we do this? The easiest, the handy one is to give atropine and epinephrine infusion or dopamine infusion. Now, cardiac pacing is also, if you see the atropine is not working and your infusion will take time to restart, you can start the patient in cardiac pacing. If patient has no pulse, even though he has cardiac rhythm or monitor showing that electrical activity, we start with the PAA algorithm. Atrioventricular ECG characteristics. The rhythm, as we said, the rate is going to be slower from 20 to 40. Rhythm essentially regular between the R to R. Okay, no B wave, absent B wave, or it might be retrograde conduction to the atria, maybe appear with the QRS, maybe hidden with the QRS. PR interval none because P wave is absent, and the duration, and you can see how wide the QRS is going to be more than 0.12 seconds. These are different, colors of different, rhythms for idioventricular cases. Anybody seen idioventricular cases, guys? Yes. So what was the cause? Acute MI Fahad? Fine. If you've seen it, what was the cause for that idioventricular rhythm? As we said, the causes could be, just to go back, digitalis toxicity of acute MI on metabolic. I've seen it with the digitalis more. Okay, I haven't seen acute MI patients with. But anyway, it is symptomatic bradycardia that follow the symptomatic bradycardia algorithm as per ACLS. Now we go to another one, which is called accelerated idioventricular rhythm. This is, exists with three or more secretion of ventricular escape beats occur at a rate of 40 to 100. Okay, and some cardiologists consider ventricular rate range to be 41 to 108, 120, but many the books and the ECG manual says 40 to 100. Also called non-paroxysmal VTAC or idioventricular tachycardia. Now the rate 40 to 100. Essentially regular, the same, no B wave, or the B wave will be hidden with the QRS. PR interval can be detected greater than 0.12 seconds. That is the characteristics of the ECG for a accelerated idioventricular rhythm. And you see how regular this rhythm. You see how wide the QRS, no B wave can be seen. What are the causes and the clinical significance for the accelerated idioventricular rhythm? It's a benign escape rhythm, appears when sinus rates slow and disappear when the sinus rates speed up, often seen after 12 hours of MI. Common after successful reperfusion therapy, and that's one, the thing that earliest, I think, this is always a question, what is the first sign for, reperfusion therapy? So when you're giving the patient, the patient given reperfusion therapy or thrombolytics, for acute MI, and he's not candidate for a cath lab, or he had a recent, stent done. And the initial, rhythm, you may see, some ventricular dysrhythmia, and accelerated idioventricular rhythm is the one that, most common appear with those patients. Treatment unnecessary if the patient is symptomatic. If the patient is symptomatic because of loss of atrial kick, atropine may be ordered. Cardiac pacing, if no pulse, CPR, follow the algorithm for PA. Ventricular tachycardia exists when 3 or more PVCs occur, immediate succession at a rate higher than 100. So we have more than sustainable, PVCs. When we say non-sustained VT, a short that lasting less than 30 seconds, and sustained VT versus more than 30 seconds. VT may occur with or without, pulse. Now, a patient may be stable and or unstable. Now, VT may originate from ectopic focus or in either ventricle. Rofayaj is asking what time we'll finish. We have only 2 sessions left afternoon, the ventricular dysrhythmia and the atrial arrhythmia. So hopefully we're going to be going earlier than yesterday. So VT may originate from an ectopic focus in either ventricle. The QRS complex is wide, as you can see, and in a bizarre shape. This is not the normal shape of V wave. Most of the time is not visible, and here no relationship to QRS complex. The ventricular rhythm is usually regular and maybe slightly irregular. We have the monomorphic VT, which the shape looks the same, and the amplitude the same, and the polymorphic VT, which is called the dorsalisty points. QRS complex vary in shape and amplitude. Sustained monomorphic VT is often associated with underlying heart disease, particularly myocardial ischemia, and rarely occurs in patients without underlying structure. So you will not see this rhythm, in patients who are, having different issues. It's mainly, it happens with a cardiac patient or having ischemic heart disease, cardiac issues. Ventricular tachycardia, other causes: cardiomyopathy, cyclic antidepressant overdose, digitalis toxicity, mitral valve prolapse, trauma, myocardial contusion, and invasive cardiac procedure, acid-base balance. Electrolytes remain one of the causes as well, and increased production of catecholamines, fight, scared, fear, or cocaine abuse. What is the clinical significance of this rhythm? It's considered one of the lethal rhythms. Okay, it may proceed to patient to a shock. Patient have chest pain, hypotension, shortness of breath, pulmonary congestion, congestive heart failure, acute myocardial infarction, decreased level of consciousness. What is the treatment for ventricular tachycardia? What do you think the treatment? Can you answer me, please? What is the treatment for ventricular tachycardia? Excellent, Fatima. We're talking about first. Let's talk about the stable. Dr. Anwar said defibrillation, pulseless shock. So we're talking about pulse without pulse. So the goal is to decrease the atomicity of irritable ventricular foci. That's the most important thing, and improve patient cardiac output. How do we do this? If a patient, with a pulse stable, we're talking about, stable patients, we give amiodarone, you give a bolus of amiodarone, also you give an infusion. Now it did not, convert with the amiodarone, especially if your patient is stable, the window is open to call cardiology, even from the beginning if your patient is stable. If dorsalis D points, always consider magnesium replacement. Unstable VT is synchronized cardioversion. This is with pulse. Now, if no pulse, this is considered, a pulseless rhythm. So you start CPR, early defibrillation, epinephrine, and you follow the ACLS guidelines for this CPR. And if it's persistent VT, you're gonna give amiodarone or lidocaine during the cycle algorithm of the pulseless VT. Monomorphic will be the shape, essentially is regular. A rate of ventricle is 100 to 200 beats per minute. P wave may be present, may be absent, okay? PR interval none, and QRS, as we said, is more than 0.12 second. These are example of, regular and some irregular monomorphic VTAC. The polymorphic, or the other name, which is we call it, dorsalis D points, okay, refers rapid ventricular dysrhythmia with beat-to-beat changes in shape, and two classification of polymorphic VTAC. Long QT syndrome, okay, acquired, heterogenic or congenital idiopathic, or normal QT. The polymorphic VT occurs in presence of normal QT interval is simply referred as polymorphic T, polymorphic VTAC, and polymorphic VT that occurs in the presence of long QT interval. This is called the dorsalis D points. Dorsalis D points, dysrhythmia between VT and VF always, there's like confusion, is it VF or VT? Type of polymorphic VT associated with prolonged QT interval. French for twisting the points. That's the name of the dorsalis D points. QR changes shape. You see the shape and the amplitude and the width of the QR is different. Appear twist around the isoelectrical line. Ventricular typically between 200 to 250, may also range from 150 to 300 beats per minute. So what is the treatment for the dorsalis D points? The characteristic, we mention it. The causes may be precipitated by slower heart rates, associated medication, electrolyte disturbance, and that of prolonged QT interval. Any medication that causes magnesium, okay, a prolonged QT interval may be congenital or acquired. Medication that can cause a QT interval prolongation, and intervention, okay, for that treatment. If a drug induced this, you stop it over pacing or administration of one of the following: magnesium, isoproterenol, lidocaine, phenytoin. Have you ever guys seen overdrive pacing? Anybody can answer? Have you ever seen overdrive pacing? No. Even here, I didn't see anybody using overdrive pacing. It's written in the box and in algorithm. So overdrive pacing, when you put the pacer, rate above the patient's rate, aiming to get the, re-establishing, the conductive pathway of the patients. But usually they will use magnesium, isoproterenol, or lidocaine, and phenytoin. If continuous okay and no medication did not help, defibrillation may be necessary. The lethal one, the famous ventricular fibrillation rhythm, is a chaotic rhythm that originates in the ventricles. No organized depolarization. This rhythm does not, cause or end up, causing any depolarization of the ventricle. So ventricular myocardium, quavars, no effective myocardial contraction, no pulse with this rhythm, resulting in irregular, irregular chaotic deflection of the QRS. No normal looking wave shape are visible. You cannot tell. Sometimes it might be, a course of VFib, like this one course of VFib, okay, which is easy to be, sometimes a fine VFib. So you need to make sure that, with the amplitude of your ECG, play with the gain, change the leads, okay, to make sure you are not missing a fine VFib. No B wave, no BR interval, no QRS, everything you cannot determine it in the VFib. And causes, there are many causes, with the, ischemia, myocardial failure, vagal stimulation, metabolic abnormalities, digitalis, and many causes can lead to the VFib. Intervention is CPR and start defibrillation as soon as possible. Perform endotracheal intubation, early intubation, establish IV access, and administer, epinephrine, and did not have, continue the cycle for the VFib, algorithm, including anti-arrhythmic drug. Asystole, all of you, this is not a rhythm. It does not consider rhythm. It's a flat line where there's no electrical activity in the heart, and there's no ventricular rate, no rhythm, and no cardiac output with this, flat line. Many causes could cause that, H's and T's, remember them, it comes to the asystole and BAA, and you have to confirm it in the ECG leads, change the lead, the gain or the amplitude of your ECG in the monitor, and if it's really asystole, follow the algorithm for BAA and asystole, start early CPR, give early epinephrine, and make sure that, quality of CPR are maintained throughout the cycles, and ventilation and ventilation paired with the compression 30 to 2, and consider to treat the H's and T's for the patient. PAA, it follows the same, although you have some electrical activity in the rhythm, okay, regardless what it is, it's a sinus tachycardia, sinus bradycardia, normal sinus rhythm, but there's an electrical activity that does not cause any cardiac output, does not cause any electrical activity or mechanical activity for the heart. And this is required dealing with the patient like, asystole, and follow algorithm of asystole from CPR, early epinephrine, and rule out H's and T's for the patient. These are very quick, summary about, ventricular arrhythmia with the arrested rhythm as well. So, do you guys have any questions? Okay. Thank you very much. So let's give you 2 minutes, 5 minutes, 5 minutes, take 5 minutes, guys. Stretch in your place, don't move, stay tuned, and we'll join now the next session after 5 minutes.
قبل ما نبتدي بالسيشن الأخيرة. Okay. Okay, good afternoon again, and this is our last session for our symposium. I wish you enjoyed this symposium. It was fruitful and you gained new information. وإن شاء الله بتكونوا يعني أخذتوا الأشياء اللي لازم تاخذوها خلال هيدي هالمؤتمر اللي نحن صراحة جربنا وتراي اور بس نعطيكم كل المعلومات اللي لازم تاخذوها. طيب نحن السيشن مثل ما تكلمنا، نحن أول الصباح أنا كلمت على الساينس ريزم اللي هي الاشياء اللي لازم تعرفوها از بيزك اي سي جي. ما شاء الله عليكم الكل كان بتصور صار عنده فكره عن البيزك ريزم، وتكلمنا عن الفنتريكولار ريزم ونبلش نعطي الشوك والى اخره. نحن الحين حنحكي مثل ما قلت لكم، نحن الشوك اتس كاتيجورايز انتو ديفرنت كاتيجوري. في عندنا الساينس ريزم، في عندنا الاتريال والفنتريكولار، في عندنا الشوكبل والنون شوكبل. اوكي، فاذا نحن الحين رح نشوف على الاتريال اريزمياس، ومثل الدكتور حسين قبل حكي عن الفنتريكولار، الحين حنتكلم عن الاتريال اريزمياس. فاذا نحن بهالوحده رح نركز بالاخص على 4 اريزم which is mainly the supraventricular اللي هي العلاقه بالاتريال بالتاكيكارديا. اوكي، اللي هي supraventricular okay, and we have the supraventricular tachycardia SVT, and we have the atrial tachycardia. We have the atrial flutter and atrial fibrillation. رح نركز بالاخص نشرح يعني اعطيكم كثير من شيء ما ضيع الموضوع عندكم بشكل كثير، بس انا رح اركزكم على قصه السوبرافنتريكولار تاكيكارديا وعلى قصه الاتريال فلاتر والاتريال تاكيكارديا، اتريال فلاتر والاتريال فيبريليشن. But let me go. انا بفضل فاذا نروح دغري على السوبرافنتريكولار تاكيكارديا قبل كل شيء ونشوف شو هو. خلينا نشوف قصه الاتريال تاكيكارديا. نحن مثل ما تكلمنا just a quick review، حكينا عن PQRST and what are the basic ECG that needs to be available. What are the basic that it needs to be available. QRST نجي نطلع على الRR، نطلع على الPR timing، على QRS، ونشوفها بقلب بعضها والكل صار عنده فكرة. طيب now let me ask you a question. Let's analyze this rhythm. First of all, can you tell me what are the 5 components? Are you able to see the 5 components clearly? My first question. Are you able to see the 5 components clearly? PQRST present. طيب أخت كندا، are you able to see it properly? أنت قادرة تشوفي مثلا كل شيء properly؟ مظبوط. I agree with you, it's available, but are you able to see it properly? Yes or no? Are you able to see it properly? No. It's difficult. عظيم. Why do you think it's difficult? Why do you think it's difficult? Because thank you for البهية، لأنه it's very fast. دائما الرزم وقت بيقرب على بعضه، دائما انتوا وقت if you will squeeze something، انت إذا عندكم if you will squeeze something وقت بيصير في لا سمح الله حادث سيارة. السيارة بالحالات العادية فيك تشوفوها بالنورمال واي، وقت بيصير في حادث سيارة and it will be squeezed ما بتعاد مبين بشكل كويس. مظبوط ولا نفس الشيء هون الرزم، لأنه الرزم it's very fast. أنا مظبوط مبين إنه هذه البي كيو ار اس تي، بس بتلاحظوا إنه المسافة البي ار كثير قريبة، بتلاحظوا إنه الكيو ار اس كثير ضابطة على بعضها. فإذا ليش؟ هذه بنسميها نتيجة التاكيكارديا. اوكي. If you will see here هون الريت عندنا مثل ما شفتوا عندي 1 2، عندي الريت هو 150 ل 250 بيتس بير مينت. This is what we call the atrial tachycardia، لأنه كمان الريزم اتس ريجولار مثل ما شفتوا ار 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 كله ما في شان something which is irregular all it's regular. البي ويف it's available and it's proceed QRS but it's different in shape from sinus P wave كمان but it's different لأنه ليش it's different because it's very fast. البي ار it might be shorter or longer than normal يعني بتصغر حسب الرزم لأنه الرزم نحن وقتها بيكون difficult it will be very hard to control it. And I can't guarantee for you that the rhythm always will be 120, 120, 120. It might be 120, then it might be 225, 123. You know, for this reason, لأنه بتبلش الرزم من البي ار. For this reason, it might be short or it might be long or it might be normal. The QRS 0.12 seconds. Clear? But this is what we call the first one or the atrial tachycardia. What are the treatment? You will go for the vagal manner and you will start with the adenosine and amiodarone, beta blockers, and synchronized cardioversion. What do you know about synchronized? نحن مثل ما بتعرفوا باليوم الأول تكلمنا عن synchronized cardioversion. What are the difference between synchronized cardioversion and defibrillation? شو الفرق بين الشوك or defibrillation with synchronized cardioversion? Any idea? Do you have any idea what is the difference between the synchronized cardioversion and the shock? R wave, synchronized. What else? Delivered at certain point. Excellent. What else? We can choose the voltage. ممتاز ياخذ زينب نحن بنحدد الفولتج. طيب نحن امتى or okay as complex R wave only it's synchronized. طيب نحن synchronized it's a low voltage. It's not like a shock. نحن الشوك امتى بنعطي الشوك؟ which reason we will give the shock? In which reason نعطي الشوك مش السynchronized cardioversion؟ لا مش كل الارزمه. pulses VTAC and VF excellent. الاخت الحنوف اذا in case of pulses VTAC and VF لا وعلى البي اي be careful ها ما بنعطي اخت بهية ما بنعطي شوك الا بحالتين بس احفظوهم هي البالسز VTAC and VF بس غير حالات ممنوع ينعطى الشوك pulses VTAC and VF. إذا بس تسمعوا كلمة pulseless means there is no pulse. and ventricular fibrillation بتشوفوا انه no P no QRS بتشوفوا مثل الرزم مثل بتشوفوا زي ولد اول ما عم يتعلم الكتيبه وعم يشخبط على الورقه هيك بيكون الفنتريكولار فيبريليشن لا في يشوف البي لا في يشوف الQRS لا في يشوف التي لا في يعرف الرزم والى اخره. هذه بنسميها الفنتريكولار فيبريليشن. والبالسز فيتاك بتكون هي but there is no pulse kind of tachycardia but there is no pulse. طيب but this is the first indication for shock اللي هي pulseless VTAC and شو الفرق بين الشوك والسينكرونايز؟ هل synchronized cardioversion امتى بنعطي synchronized cardioversion؟ In which case do you think synchronized cardioversion؟ في ناس بتضيع فاذا there is a huge difference بين السynchronized cardioversion والشوك ما تضيعوا بينهم. امتى بنعطي synchronized cardioversion؟ unstable supraventricular tachycardia ventricular VTAC plus excellent شيماء نحن ventricular شو قلتي ventricular tachycardia or pulses with pulse انتبه البالسس يعني no pulse اخذ شمت ممتازه VTAC with pulse يعني في موجود pulse ما تضيعوا بين pulses VTAC و VTAC with pulse. pulseless يعني ما في pulse at all ما في pulse نهائيا. هون عم VTAC with pulse يعني فإذا بنعطي فإذا in case of أنت بنعطي synchronized cardioversion اللي هي بهالحالات التالية اللي هي atrial fibrillation. Let me show it to you here. وقتها يكون عندي atrial fibrillation or atrial flutter or supraventricular tachycardia. هي الاتريال ريزم. Anyway, as in this is a low voltage, but what is the difference? It's a painful. مشكلتها انه it's painful. مشان هيك sometimes you will give the patients that kind of sedation. It's painful. هي موجعة spontaneous cardiopulmonary. اوكي فاذا this is a difference. الحين رح نتكلم على اول شيء اللي هي supraventricular tachycardia اللي مثل ما حكينا حطوا بدايتكم قصه السynchronized cardioversion وطبعا الاتريال اللي هي supraventricular tachycardia, atrial fibrillation والاtrial flutter. اوكي. Supraventricular tachycardia, it's a narrow, complex QRS tachycardias that are known to originate above the ventricle. The rate is between 140 to 300. It's a very fast rate. فإذا نشوفوا الريت بالsupraventricular tachycardia, it's a very fast rate with 140 to 300 beats per minute. فإذا الsupraventricular tachycardia, where the rhythm it's very fast, between 140 to 300 beats per minute, which is too much. The supraventricular tachycardia, the P waves is not visible. ليه؟ لأنه أنت عم تحكي برزم 140 وabove، ممكن توصل to 100 whatever. مشان هيك it will be impossible or it will be very يعني it's no way just to see the P. بتحسوا البي مثل كأنه يعني ما بتلحق شو بيصير؟ ما بتلحق البي تنتهي إلا بتطلع لأنه الرزم it's very fast. The term SVT is used since without P wave it's not possible to know for sure where is the dysrhythmias originating. مشان هيك لأنه very P it's very fast, it will be impossible to know where this arrhythmias is originated. من وين نبلش؟ This is the SVT. Can you analyze for me this rhythm? مين ممكن who could witness and tell me or to analyze for me this is SVT supraventricular tachycardia. قبل ما أعطيكم المعلومات عنها now I will depend on your critical thinking. بدي أشوف أنتم كيف صار فيكم تحللوا الرزم. No P waves. I can't say there is no P waves but you couldn't see it يا أخت عايشة مظبوط؟ أنت هلا الحين مش شايفين حتى أنا I cannot overlap thank you كندا. It's not no P wave هي موجود but it's overlap. هلا قلت لكم أنا أول شيء يعني ما بتلحق تطلع إلا بتنزل. يعني ما بتلحق تبلش إلا بتنتهي because لأنه الرزم it's very fast. It's a narrow QRS thank you. Regular thank you. Excellent. والله معلوماتكم جدا مهمة وجدا قيمة. Rate it's very fast مشان هيك it's overlap with P. ما عم بقدر أشوفها. I cannot see it. QRS it's a prism. عظيم. P بتشوفوا ال P waves it's overlap but P wave it's hidden in the T wave. يعني ما بلحق ما في يميز ال P عن ال T. لأن الرزم نحن وقت كنا عم نحكي عن السوبرفنتريكولار تاكيكارديا شو قلنا الرزم تذكروا the rate is between 140 you could imagine someone he has a rate between 140 to 300 very fast rhythm. P wave hidden but the QRS it's normal حتى رغم إنه الرزم it's very fast but still the QRS it's normal. كمان في عندنا الباروكسيمال supraventricular tachycardia which is this is SVT that start and suddenly. يعني شوفوا بتبلش and suddenly like what happened here. شوفوا كل شيء supraventricular suddenly شو صار هون and it will. طيب فإذا let's practice this one مثل ما حكينا إنه هون. This is what are the rhythm here. شو ممكن who could analyze this rhythm for me. مين ممكن يعمل لي analyze الرزم هنا؟ أنا I could see two rhythm كمان مش دايما يعني I could see شايف أنا عندي two rhythm مش one rhythm only. Who could analyze it for me? Starting by SVT. خد بهية. طيب starting وشو صار بعدين؟ Then regular. Thank you. انتبهي. خد فاطمة. لو انتبهي كثير. انت بتقولي لي it's converted to normal rhythm. I agree with you. but ما تقولي it's after giving the patient shock. ما نعطي shock إلا بحالتين. pulses في تك NVF. انتبهوا كثير منيح. ما بنعطي شوك الا بالحالتين pulses في تك NVF. نحن انا هون لا عندي لا pulses في تك ولا عندي EVF. شوفوا شو عندي انا. This is a supraventricular tachycardia. ليش؟ لأنه rhythm it's very fast. It's at least 140. وشفتوا ال P I cannot see it. It's overlap. QRS it's normal and Q it's like AT لأنه بتحسيهم في AT ببعضهم. But what happened here? supraventricular بعدين it's here converted to normal rhythm. أنا كان عندي supraventricular. شوفوا شو صار عندي. PQRST بعدين PQRST. شفتوا PQRS it's converted to a normal sinus rhythm. إذا دائما الرhythm أنا ما بيعني إنه إذا أنا كان عندي. Why do you think it's converted? What are the reasons? Why it's converted to normal sinus rhythm? For what reason? Thank you أخت شيماء. Maybe after management. احنا شفت أنا على المونيتور مالي supraventricular tachycardia. أعطيت الفيجال مانير أو أعطيت شو؟ Or what? أعطيت shock? Or what? Synchronize. Thank you. أعطيت synchronized cardioversion والمريض it's converted to normal sinus rhythm. مثل ما شفت إذا supraventricular then normal sinus rhythms. SVT converted to sinus rhythm. تذكروا أول ساعة شو قلت لكم ما تضيعوا بين الساينس ريزم والساينس أريزمياس. ساينس أريزمياس يعني شو الساينس أريزمياس؟ كل شيء نورمال بس صدقني بشيء فرد بيكون في نت يعني ريجولر. يعني أريزمياس اتس abnormal. ريزم ساينس ريزم اتس نورمال. هي إذا بدك supraventricular tachycardia then converted to normal sinus rhythm after giving the cardioversion. How to manage a supraventricular. تذكرتوا كمان أول ساعة أنا شو قلت لكم؟ إنه نحن المانجمنت مش بس ما بنعتمد نحن we are not treating a machine. Put this information on your mind. We are not treating a machine. We are treating a human being. يعني أنا ما في أعتمد بس على الماشين. إنه أعطيتني supraventricular tachycardia. لا أنا I will depend mainly on the ECG result yes. But on the clinical symptoms of the patient. يعني إذا المريض كان asymptomatic and we have or stable. يعني I will use the word stable and unstable. Stable يعني عنده SVT but he look well. There is no problem. What I will do in this case, I will send him home. No, I will keep him under close observation. ده رأى المريض ونشيل إنه شيء إنه كل شيء أوكي. هلا if asymptomatic but stable, treat the cause and vigorous stimulation beta blocker. But if the patient is unstable at this moment, we need to go for synchronized cardioversion. I need to do the synchronized cardioversion. And what are the main treatment for a patient who has an unstable supraventricular tachycardia? What are the main treatment? What are the main treatment for the patients who have an unstable supraventricular tachycardia? How we need to treat them? By synchronized cardioversion. Yes. يلا شدوا حالكم انا بعد فيها نص ساعه. صار لكم 3 يعني عم تشاركونا بشكل ممتاز 3 ايام يعني بعد it's half an hour and we'll be done. وكيف أذن synchronous كالريفرجن. طيب فإذا supraventricular tachycardia it's clear which is kind of atrial. I know you are tired at the end of the day. كلنا هيك بس يلا بعد نص ساعة مشان نعرف إنه المعلومة أنا بهم المعلومة توصل عندكم كل المعلومات توصل عندكم بشكل ممتاز. عظيم. طيب نحن رح نروح على نوع ثاني من الأدريال اللي هو الأتريال فلاتر. دائما it's mainly the same line of treatment but إنه you need to know how to read it. Extremely rapid atrial rate, which is of a so flutter waves, F waves. Regular atrial contraction, however, it sometimes lasts due to. طب شو لاحظتوا هنا بالريزم؟ I will show you the rhythm. What did you notice in the rhythm here? Can you analyze this rhythm? Irregular. وين شفت الirregularity يا أخت بسمة؟ شو هو الirregular اللي لاحظتيه؟ البي waves. Irregular rhythm before the curve. Regularity. Regular rhythm, yes? Not every P is followed by QRS. Rapid, but it's most likely irregular. No clear P waves. What else? No shape. خلينا نشوف. طيب خلينا نشوف. أول شغلة إذا بتشوفوا هون الاتريال rate in 200 to 350 beats per ventricular rate variable. Rhythm regular, ventricular regular or irregular. P, no identical P waves. PR not measurable. والQRS usually less than 0.12%. اللي لاحظته أول شيء بتشوفوا إنه الريزم it's mainly regular and sometimes irregular, but it's mainly regular. But the atrial rate it's very high, 250 to 350 per minute. You could imagine the atrial rates it's 250 to 350 beats per minute, and but it's the rate it's mainly atrial it's the atrial it's regular. طيب, do you think how we could treat هذه بنسميها this is what we call the atrial flutter. Do you think how we could treat this case? تذكروا على التريتمنت تبع الاتريال how we could treat this case. كيف ممكن نعالج هذه الحالة؟ Synchronized beta blockers. Check if the عظيم. Thank you أخت زينب. أهم شيء بدي اسمعنا بس check if stable or not. But mainly with this يعني about 250 or 300 bits per minute يعني it's going to be unstable for sure. Mainly same as atrial fibrillation. شو يعني atrial fibrillation؟ قصدك same as أخ ناصر قصدك same as supraventricular tachycardia, do you mean? It's mainly going to be the same line of treatment. ما كثير رح يكون في فرق. دائما الكوز أول شيء what are the causes؟ دائما we need to treat the cause. نحن بكل شيء هذا مثل ما حكيت لكم بأول session always we need to treat the cause. يعني عندنا it might be pulmonary embolism, it might be thyrotoxicosis, ischemic heart disease, hypoxia and digitalis toxicity. إذا نحن الكوز تبع الاتريال فلتر we need to treat the cause. دائما نرجع للسبب، شو السبب اللي خلى يصير في عندنا الاتريال فلتر؟ It might be pulmonary embolism or it might be thyrotoxicosis or ischemic heart disease or hypoxia or digitalis toxicity. هذه كلها ممكن تسبب الاتريال. كيف المريض دائما severity and signs vary on the ventricular rate, duration of the dysarrhythmias and patient cardiovascular status. Mainly يعني كيف المريض كيف تعرف he will have a palpitation and the rhythm it's very fast mainly and he's going to have kind of palpitation or skip beats, weakness, dizziness or chest pressure and دائما مع الاتريال والمرضى many they will go for palpitation. يعني patient will feel بس انه في عنده نوع من palpitation او ضغطات القلب he will feel it. plus حيكون في عنده weakness, dizziness he will feel like a dizziness or بحس مثل بلاطة على الصدر بنسميه like a chest pressure. إذا he have like a chest مثل بحس مثل بلاطة أو بحس مثل هيك ضغط على جهة الصدر. فإذا كملنا البلاك close the sink. مانجمنت دائما مثل ما حكينا with all type of rhythm نحن بدنا نشوف if the patient is stable or if the patient is unstable. دائما بتختلف الموضوع بين stable وال unstable. regard إذا كان stable there is line of treatment and if the patient is unstable there is another line of treatment. If the patient is stable, do you think how we could treat the patient? If the patient is stable, we will go and give the anti-arrhythmias مثل الاميودارون, الكالسيوم blockers, beta blockers, heparin and digoxin. If the patient is unstable تذكروا فإذا دائما بالأتريال لو سمحتوا معلومة جدا أنا بعرف إنه رح تكون it will be very difficult for you to memorize everything. ما راح فيكم تعملوا ميمورايز لكل الانفورميشن بس الاكسبكتيشن انه تعرفوا الكي بوينتس. هودي الكومبوننتس تبع الاي سي جي. انا في عندي شوكابل ونون شوكابل. شوكابل ريزم وقت بدي اعطي شوك، وقت ما بكون عندي شيء من الكومبوننتس مبين. وتذكروا قصه الولد اللي بيصير يشخبط على الورق اول مره، هذا بنسميها الفنتريكولار فيبريليشن، ما بينعرف شيء من شيء. البلسز فيتاك كمان بنعطيهم هودي شوك. النون شوكابل امتى بنعطي من النون شوكابل ريزم؟ بدنا نعطي synchronized cardioversion. synchronized cardioversion امتى بنعطيها؟ synchronized cardioversion بنعطيها وقت يكون في كل type of tachycardia اللي هي الاتريال فيبريشن والاتريال فلتر والسوبرافنتريكولار tachycardia. انا بروح على synchronized cardioversion which is a low voltage. مش كل مجرد ما اشوف اس في تي او اتريال فيبريشن دغري بروح على الكارديوفيرجن. نو اتس painful. أنا بدي يكون it's asymptomatic. synchronized cardioversion بدها تكون بدها تكون symptomatic أو unstable, not synchronized cardioversion. والanticoagulation less than 48 hours heparin than cardioversion. If more than 24 hours, you give warfarin and okay. الاتريال فاذا هذا الاتريال مثل ما قلنا الفلتر. نعم شوفوا لي الاتريال فيبريشن. What did you notice؟ في شغلتين بتحسوا في شغلتين رح شرحهم اياها يعني we need to notice على الاتريال فيبريشن. What did you notice here؟ irregular. والله انا مبسوط كويس انه دغري عم تقدروا تعملوا identification للرزم. I am very happy and glad with this. اول شغله لاحظتوها بتلاحظ الاخت قايلين انه it's irregular. بنشوف هون مسافه من هون لهون. It's not the same. It's not the same. It's same. شو الفرق بين اول فرق؟ فاذا بعرفوا انا كيف بميز الاتريال فيبريشن عن الاتريال فلتر؟ اول شغله بميزها شو بيصير بالاتريال فلتر؟ الرزم كيف كان؟ الاتريال رزم اتريال فلتر regular. Thank you so much. It's regular. No different. بالاتريال فيبريشن it's irregular. Definitive it's irregular. هونيك it might be regular or irregular. هون it's definitive or definitively it's irregular. مثل ما شفنا. It's not regular at all. It's irregular. هاي أول شيء. ثاني شغلة كيف بتشوفوا البي هنا؟ كيف شايفين؟ Like what؟ بتحسوا مثل شو؟ What did you notice؟ مشان تقدروا تميزوا بيناتهم. رجع بالكم أنا بعتمد كثير على قصة الانسبكشن النظر أكثر ما يكون نتأمل ونعد بالإمرجنسي. VF like but in P wave. اوكي وات ايلس؟ في شغله كمان لازم تعرفوا تميزوها بالاتريال فيبريشن. وات ايلس؟ في شغله هيك واضحه يعني انتم اذا بتشوفوا الصوره فيك تميزوها دغري. You could see clearly. No P waves. What else؟ كيف شايفين هذه؟ كيف شايفين هون هيدا الرزم اللي هي؟ بتحسوا شيء زي المنشار او النايف. كيف راس النايف بتحسوا مثل شغله مثل ستيكي هون. شوفوا يعني نوبي مش واضحه بتحسوا مثل شغله صوتوس اكسلنت يعني بتحسوا مثل شغله كيف النايف راس النايف راس السكين راس النايف هيك بتحسوها مثل شيء كثير مروس. نوبي ويفز. فاذا شو كيف بتميزوا بين الاتريال فيبريشن والاتريال فلتر؟ الاتريال فلتر it's mainly irregular. It's mainly regular. It might be irregular, but it's mainly regular. I could identify P at somehow. With atrial fibrillation, ما في, there is no P waves and there is, it's always irregular. Okay, this is how to identify the difference. هيك انتم فيكم تعرفوا الديفرنس بين هودي الاثنين. This is the way to see the difference. Do you think how we could treat? Coming up for more information on multiple, and this is the difference مثل ما شفتوا هون. هاي الاتريال فيبريشن. I will leave it to you just to see it. شفتوا شو الرزم هون؟ لاحظتوا كيف؟ شو الاتريال فيبريشن؟ لاحظتوا هون؟ هي مضبوط. شوفوا الاتريال فيبريشن والاتريال فلتر it's mainly the same. يعني هي انا ليش عم بعطيكم اشياء تتعب الاتريال فيبريشن. تذكروا انه دائما البي مش مظبوط، تذكروا انه اتس اولويز irregular، ما راح تكون ريجولر، وبتحسوا زي البي ما بتشوفوا البي، بتحسوا شيء طالع زي الراس. تذكروا the head of the knife، راس السكين او النايف، بتحسوه كثير مروس من فوق. مظبوط. This is head of atrial fibrillation. I know I agree with you it's similar، بس اللي عم بعطيكم برجع لكم باي انسبكشن بتشوفوا انه الار ار نوت ريجولار، هونيك might be regular most of the time. هون الريجولار زيت الشيء، هون بتحسوا نو بي ويف، بتحسوا زي المنشار او زي السكين، راس السكين على يعني كثير مروسه على الناس. This is how different. هلا regarding the line of treatment it's mainly similar، it's mainly the same. انه بتحسوا انه في فرق مثل ما قلت لكم، انا عندنا شوكابل ونان شوكابل والى اخره. شوفوا الرابيد اتريا ريت of 300 to 600 beats per minute in atria or fibrillate. How is patient doing? Ineffective atrial concentration, subsequent decrease in the cardiac output and loss of atrial blood flow. Terminal ECG characteristic rate, it's very fast, 300 600 beats. Rhythm, ventricular rhythm is irregular, and the P waves it's not identifiable, and PR I cannot measure it. With a QRS demand, it's less than 0.12 seconds. This is the characteristic. Just see it very well قبل ما ننتقل على الرسم الثاني. مثل ما حكينا زاسين اسفل. الكوز تبع هي it might be caused because of coronary artery disease, congestive heart failure, mitral or tricuspid valve disease, hypoxia, drugs, electrolytes imbalance, hyperthyroidism, pulmonary embolism. This is all the cause. Always check the patient. مثل ما قلت لكم نحن دائما ما بحياتنا نعتمد على الماشين. We are not treating a machine, we are treating a human being. فإذا نحن ما بنعتمد على ريزلت الاي سي جي، لا بنشوف معه it will give us but دائما we might treat the patient. مثلا بعطيكم مثل قصه الاي سي ستول. بدو بتشوفوا المريض اذا للوهله الاولى اذا حدا ما بيعرف الاي سي ستول بتشوفوا المريض باس اوي. طيب كيف باس اوي بعد ما فتح عينه؟ This is check دليل. دائما مثل ما نحن ما بحياتها stop. Please don't ever treat the machine. Treat the patient as a human being and always treat the clinical symptoms. مشان هيك نحن بدي لكم كقصه السيمتوماتيك والايسيمتوماتيك stable or unstable. دائما with severity of the signs and symptoms is depending on ventricular rate, on duration of the dysrhythmias and cardiovascular. Do you need me to repeat the cause? Cause, okay. Cause, this is the cause, Dr. Michael, which is the coronary artery disease, congestive heart failure, mitral or tricuspid valve disease, hypoxia, drugs, electrolytes imbalance, hyperthyroidism, and pulmonary embolism and male pulmonary embolism. So always, whatever we say that we need to treat the cause, always you need to go back to the cause, treat the cause, because once you treat the cause, you will stabilize your patient. If the patient is stable, as we said, antiarrhythmias like amiodarone, calcium blockers, or beta blockers, heparin, and digoxin. If the patient, as we said, as a unity memorized now, have unstable patient, synchronized cardio, go for the synchronized cardio version. So, now, can you analyze what did you see in the first rhythm here and the second rhythm? Can you analyze atrial fibrillation? Atrial fibrillation. Which was the atrial fibrillation? Atrial fibrillation. Above the first, thank you. And that below one. Flatter, thank you. والله ممتازين جدا. الله يقويكم ويعطيكم ألف عافية. فإذا عندنا الأتريال فيبريشن وأتريال فلاتر. ممتازين جدا. طيب كيف قدرتوا تميزوا؟ How did you differentiate? How would you differentiate between these two? P waves, more prominent in the flutter, yes. Flutter wave, thank you. Regularity, shape. Excellent. ممتازين جدا جدا جدا. Excellent. So now the last part, I'm going to give you a mock code. We will analyze it and we will end our, since now you know the atrial rhythm, the ventricular rhythm, and the sinus rhythm. But now, please, we might take another few minutes just to analyze the mock code, and we will end everything. Just a few minutes. Let's take a case scenario, and I want you just to answer all my questions to see what happened to a patient. In the scenario, we have a 34 years old male admitted through the emergency department, and he was complaining of chest pain. What you will do? Now, this is a case scenario. I don't want to include everything. What you will do? ECG, ABC, vital signs, ECG, blood labs, excellent. ECG, sample, excellent. Check vital signs. Type, okay. Now, you connect the patient to the monitor. The patient is connected to the monitor and he's doing well, no problem. Suddenly, the patient becomes unresponsive. What you will do? Check pulse. Check the pulse. Check it. Which pulse you will do? We will check. Carotid pulse, excellent. If it's pediatric, which pulse you will check? Excellent. Now we check the carotid pulse. There is no pulse. What you will do? You will go for CPR and code blue water. Now you connect the patient to the monitor. You connect the patient to the monitor. حطيته على المونيتور and you saw that the patient has a ventricular fibrillation. VF. What you will do? Shock. Because this is a shock cardiac. Excellent. Oh, please, Amina. لا. Missynchronize shock. For example, the patient is connected to the monitor and the doctor is ordered to give the first shock. after giving the first shock, what you will do? Continue CPR for 5 cycles, 2 minutes. What you will do next? After 5 cycles, 2 minutes, you will check the pulse. And what you will do at the same times, we will ask the medication nurse to do what? أنا بعمل أول شغل. What you will ask her to do? Prepare. Thank you على الكردي. Prepare. Do not give. بعد ما أعطيت أنا الإبنفرين. I need to prepare. How long? What is the dosage? 1 milligram. I will ask to prepare. Fine. After 5 cycles, 2 minutes, I check the carotid pulse. There is no pulse. What I will do? Check rhythm. أذن شو بقول؟ شياكة. There is no pulse. I will give the second shock. قبل CPR. I will give the second shock followed by CPR. And at the same time, now I will ask the medication nurse to give the epinephrine 1 milligram every 3 to 5 minutes. فإذا هون إلا خلص automatically ما في لزوم بقى كل مرة إلا خلص. Since I start the second shock, I will ask just to give epinephrine 1 milligram every 3 to 5 minutes automatically without coming to me. But I give the second shock. What I will do after the second shock? What to do after the second shock? But no, not continuous. What I will do before continuing the CPR, check the pulse. They not only we check their pulse. There is no pulse. What to do? Give the third shock followed by ما في أعطي أنا shock CPR ذات الوقت. I will give the shock followed by CPR and already the epinephrine is going on every 3 to 5 minutes, and I will ask just to give the amiodarone as mentioned of you. And I will, what to do? I will check the causes, which is the 5H and 5T, which is the 5H and 5T. Okay, so this is what should be done. Clear? What had scenario? The first scenario. Let's take another quick scenario. You have a patient coming through the emergency department and he has a palpitation. You connect the patient to the monitor and you identify that the rhythm is very fast, but there is no other signs and symptoms. What you will do? What you will do? ECG, check pulse, monitor, and patient is stable. There is fast rhythm, but there is no signs and symptoms. Keep the patient under close monitoring. Suddenly, the patient he starts to have hypotension and decreased level of consciousness and headache and palpitation and whatever. What you will do? Check the pulse. The pulse is 180, and you identify a supraventricular tachycardia. What you will do with the result? 406. Thank you. Synchronized cardioversion. Hala, if you will have the same case of the patient who have been admitted and he has a, let's say he has a bradycardia and of 50, then it's going low. See bradycardia, but synchronized cardioversion. We will go for pacing, cardiac pacing, على الكاردياك لأنه to avoid to going for the block. Okay? Clear? هل المعلومة صارت واضحة بالنسبة لكم؟ إذا this is just to quick review إنه نحن بنبلش بالسوبرافنتيكولار تاكيكارديا في عندنا شوكابل نون شوكابل ريذم النون شوكابل اللي بيجي تحته اللي هي نورسينكرونايز كارديوفيرجن والى اخره. طيب just quick review. Any question related to the 3 days that we started with you? We have أي سؤال بتحبوا تسألوني إياه؟ قصة الترياج or trauma or shock or medication. Do you have any question that you would like to ask me before ending the symposium? Any question? We are ready to answer you. The PowerPoint, I think everything is recorded on the YouTube. You could access it at any time. And the PowerPoint, you will talk with the coordinator. Just for us, we are just a speaker. That's it. يعني نحن شرطنا بس to speaker. Just see with the company if it's possible for this. Anything, any question على الطياج? If you would like to add to critical emergency, هي بنعمل عليها 3 weeks symposium. نحن 3 days we cannot include everything بس نحن جربنا نعطي المعلومات المهمة اللي لازم تاخدوها، يعني الاشياء اللي لازم تاخدوها من كل شيء. بس ما فينا نعطي كل الاشياء على critical care and emergency. It's a very wide topics كثير فينا نعطي كثير بس احنا جربنا نعطي من كل شيء شوي everything. I will give you another 1 minute to see if there is any question that should answer it for you before ending everything. الابنفرين every 1 milligram every 3 to 5 minutes. الابنفرين وقت ما نبلش بعد السكند شوت نعطيها بصير every 3 to 5 minutes we will give الابنفرين. automatically every 3 to 5 minutes. Shock followed by CPR. Okay, Fazan, thank you for your attendance. Much appreciated. Inshallah, we will see you with